Councillor, we're live.
Hello everybody and welcome to this virtual meeting of the Adults and Community Scrutiny Committee. I hope you've all been keeping safe and well. As virtual meetings are new to all of us, and I do apologise because obviously I've got David's spiel and advice written down here on my own iPad. I'd just like to highlight some of the procedural differences in place for this meeting. Please note that this meeting is being recorded and it is going out live. I mean, I don't need to ask for respect, I know we're going to get that from all of our cabinet members as well. So what I would like to say is that so the meeting can be managed as effectively as possible, because as I say, it is new to all of us. There are certain things that we really must all try our best to adhere to. So first, can you please only speak if you've been asked to do so? Too many people speaking at once just basically wipes the system clear. Secondly, for some people who haven't been able to get the visual means up to watch the meeting, can you always speak your name before you actually do speak, just so that people can see who you are or hear who you are? Thirdly, if not speaking, it's one of the things that we found there just during the pre-feed there, is if you're not speaking, can you please make sure you mute your microphone, because otherwise we get all sorts of feedback going on. David is at the meeting, and if you do forget, David will actually mute you once you finish speaking. Those wishing to speak, please use the meeting chat. As Alison has already explained, it is the second button down underneath the bell, and then either her or David or myself will try to keep watching who wants to speak next. But if we make a mistake and we get people out of turn, it's just one of those things, because it's new to all of us. So what I would ask as well is, again, is what Alison was saying, is that we will hear the whole of the presentation before we ask questions, because a lot of the questions I found reading through the presentation that I had were actually answered as part of the presentation. So we will take questions after the presentation. But one of the other things is please also be aware that everybody who's tuned into this meeting can actually read everything you put in the meeting chat. So again, respect. So this is the more formal part. Any recommendations of the committee requiring a formal vote will be carried out by myself, asking for a spoken response either for, against or an abstention. If you don't hear all of the debate that's going on, please let me know, and obviously that will require you to have an abstention, because it is important that we don't vote on something that we haven't heard all the arguments or all the details about. The last thing or one of the other things is that should my connection as a chair be lost throughout the meeting, Lynn, as my vice chair, will take over. There may be a short adjournment, but Lynn's very capable, so I can't see the need for that. Hopefully there won't be a need for that until the connection is resumed. Also, this is going to make you laugh, this one. Can we please try and keep background noises to a minimum? Now, I've got 2 black Labradors in the house, so if anybody knocks on the door, they're going to go wild. So just please be aware, they're not going to go and eat me, but they will go wild. But it's just, again, just to try to help matters go along as easily as we can. One of the other things I was going to say is that, as we do at previous normal meetings, face-to-face meetings, is that when questions are being asked, members of the Scrutiny Committee will be putting their questions before cabinet members. And the last thing I want to say before we actually go on to the agenda is this is going to be difficult for us. I was at a tour meeting yesterday and I could feel myself going stiff. Please just make yourself comfortable. If you need to go and get yourself a cup of coffee, just on video yourself, go and get a coffee, do a bit of stretching, do a bit of shoulder rotating. And we're the first ones to do it for Redcar and Cleveland, so let's get on to it. Let's see if we can enjoy it. Let's do our best and find out the information that we can do. Right, thanks very much, everybody. And if we just proceed now, when I find it on my own iPad, the agenda items. So I've lost it. Aha, I found it. Yeah, so our first agenda item is apologies for absent and any members who are actually substituting for members who can't make it.
Councillor Brady and Councillor Rob Clark, although I think I've got Councillor Brady on my screen at the bottom as attending, as joining. For you, David. He's not, I've got those apologies. Councillor Brady and Councillor Rob Clark then.
Right, thank you.
Yes.
And I know it was a long time ago, but can we confirm the minutes that were held on the meeting on the 3rd of March 2020? Are they confirmed?
Chair, perhaps if somebody wants to just briefly unmute their microphones to
I'll
those minutes.
confirm them, Chair.
Right, thank you.
Confirmed, yeah.
Is that seconded?
I'll second.
Thank you. Right, declarations of interest. There's not a green form going round, so can I just ask that you just inform Alison if you've got declarations of interest, if you let Alison know after the meeting of anything that is coming up. I think that's probably the most sensible way to do this.
Yes.
Is that okay, Alison?
That's absolutely fine, but I would just say if there is a relevant declaration of interest during the meeting, that it's helpful for the member to declare that at the point in the meeting as well.
Well, if they do that on the chat, is that okay?
I think it's probably best to just do that verbally. We have a record of all of your interests and we can check that afterwards, but I would ask that they just make that verbal so that anybody listening as well will understand that there's that interest there.
Right, thank you. We'll follow Alison's advice on that. I mean, that's why she's one of our officers. So we're now going to go on to the presentation for the COVID-19, but prior to Patrick actually leading us through the interest, Rob is going to say something, just because obviously that links in to the COVID-19 presentation. So I'm going to unmute myself. I've got to mute myself now so I can hand over to Rob.
Thank you very much indeed, Chair. Good afternoon, Chair. Good afternoon, members. I hope everybody can hear me okay. I can see one or two nodding, that's good. So this particular report that's on the Cabinet agenda has been prepared across all of our directorates because, of course, COVID has affected all of our service areas right across the board. The report itself as a written document was finished last Monday. Clearly, this is an emerging issue, so some of the picture is constantly changing. So clearly the written word won't always be the most up-to-date picture. I'm mindful that this is an adult and community scrutiny. So I think the impact of COVID on adults and health is the key focus for this afternoon. And clearly the report I've done for Cabinet covers everything, but we don't really want to get tied up into too much detail across other service areas. You've also got a presentation to follow, as you know, from Patrick, which covers in much more detail the impact on adult health and social care. So you'll get much more detail there. Cabinet did request a broad overarching report, which is what is in the Cabinet pack. That's the one I've put together for Cabinet members. I don't intend going into lots of detail about any specific services across the council during this brief presentation, but it's really to focus on the overall approach that the Cabinet report takes in relation to COVID prior to the detail you'll get from Patrick's presentation. So turning to the report itself, as I've said, it does cover all aspects of the council's operation, covers all the council's priorities. It really does impact very, very widely. In response to the COVID-19 crisis, the report takes account of government guidance that's been issued ever since March, advice and emergency legislation that's coming out, and of course the council's considered response to everything as it emerges. So the report does focus on basically what's happened since lockdown on the 23rd of March, which heralded a fundamental challenge for Redcar and Cleveland Borough Council, probably something none of us would ever have anticipated before. It should also be remembered that this particular crisis occurred whilst we were still very heavily involved in the response to the cyber attack. And to be honest, we still haven't fully recovered from that. So to be dealing with the two things together has been really quite incredible. So two catastrophic events running into each other is utterly unprecedented and underlines, I think, how well the council and our whole staff team have performed in order to maintain services. This report won't deal with every aspect of the crisis. It can't. It would have to be the size of a phone book in order to do that. But it does set out how we've responded so far and also how we intend to plan for the future. It's not possible to define what the future will look like, and the recovery phase is likely to last for many years, and that will be an evolving picture as we go forward. But hopefully this report will assist all members in their scrutiny role to help shape the council's response and ultimately our direction of travel as a council, as a borough, as we emerge from the crisis in the years ahead. So the main purpose of the report really is to try and establish some kind of strategic overarching approach to COVID-19. And in paragraph 2.6 of the report, the 5 strands of this particular strategy are set out, and I'll just repeat them quickly. The first one, to preserve the life of citizens, staff, frontline workers and vulnerable people. 2, to respond proportionately and flexibly to the crisis, in partnership, being mindful of the council's own financial sustainability. 3, to continue to deliver key services safely and appropriately. 4, to prepare for service recovery, resetting and restoring of services, with a prioritised plan in place for each, to be ready for sequential government changes in lockdown arrangements. Bit of a mouthful, that one. And number 5, to be as resilient as possible across our services and teams, so we can be ready to react swiftly to change as the new normal emerges, whatever that new normal is. I hope you can agree, there is a logical flow from lockdown really at number 1 in those 5 through to the new normal emerging in the future in number 5. So the purpose of this report is to try and provide a structured approach to what we have done and what we intend to do. I'm not going to go into a great deal of detail, as I say, but just a few words on each of those 5 areas. So the first part of the strategy about preserving life of citizens, etc. We established the Borough Emergency Centre, which was bringing together key people in order to help us make sure we had the best advice in one place. We arranged for our staff to be self-isolating and shielded and so on in response to government guidance. We've implemented working at home on an incredibly grand scale, which is helping to protect staff in a way we've never had to do before. We've protected our residential care population, and you'll hear much more about that from Patrick's presentation. We've engaged with our service providers because we commission a number of services as well as providing them directly. And especially we've engaged very heavily with providers in relation to services for some of our most vulnerable people. We've had regular COVID-19 briefings internally for staff, daily briefings for all members of the council, and regular briefings to the media as well to keep everybody informed. And we've used social media a great deal in order to get the messages out there to our communities. We've bolstered levels of volunteering support right across the piece, both within our staff teams, but also our fantastic communities. Again, through social media channels and other things, but obviously working closely with bodies like the Redcar and Cleveland Voluntary Development Agency. But of course, we also had to close a range of council services in order to protect the public and staff. And the report does list, I hope, the majority, if not all of those ones that we have had to change, to close and suspend. The second section of the strategy around responding proportionately and flexibly in the crisis. We're pointing out there that we've engaged fully with what's called the Local Resilience Forum, so that's at a Cleveland level, but also engaging regional and national networks across local government, central government and public health. That's to make sure we've got access to the most valuable information and advice, as well as channels in order to feed local concerns and issues right up into central government. Locally, we established the Community Support Hub. Our teams have done a fantastic job there, and you can see some figures in paragraph 2.8 as at the end of May, the sheer numbers of phone calls and emails that have been made and received, and the numbers of food parcels that have been delivered to some of our most vulnerable people in the borough. That has been a fantastic piece of work. We've also had to establish immediate supply chains for essential foodstuffs during that period. And if you remember when lockdown first hit, many of our supermarket shelves were pretty empty anyway. So again, an incredible job to get that supply chain set up with lots of suppliers so that those food parcels could be delivered. We've worked very closely with bodies like our NHS trusts, Public Health England and so on throughout this. And again, Patrick will cover more on that. We're also in a position where planning is underway following government announcement towards the end of May about this borough with Middlesbrough being a pilot for test and trace programme. So that no doubt you'll hear more about that a bit later on as well. As part of the initial response, we've given money to the Voluntary and Community Sector Emergency Fund, which is helping small groups right across the borough deal with their ongoing financial pressures to stop small groups going under. We've also given £15,000 to RCVDA so that they don't need to furlough staff. Really important to keep that sector going. We're going to need the VCS more than ever before. Members will be aware, because of the daily briefings, the amount of support that's being given to local businesses, and at the time this report was finalised, more than £21 million had been awarded to small businesses to help them through lockdown. We've also paused the development of a lot of our capital projects whilst we review business cases for them in terms of what all this might mean for their success going forward. The third strand of the strategy, this is about continuing to deliver key services safely and appropriately. The Borough Emergency Centre has placed a lot of effort on working with each directorate so that we can plan the provision of prioritised services, the most important services, based on the available staffing, bearing in mind that some staff have had to be either working from home or shielding and so on. So there's been a huge amount of effort done there, but many vital services have continued to be operating, especially to support the most vulnerable. And in paragraph 2.9, there's a series of bullet points for each directorate to give some examples there of the kinds of work that's being done. We've continued to work hard to secure sufficient appropriate PPE, the protective equipment for our staff and for our commissioned services. That's not been easy, and again I'm sure Patrick will cover more of that in a little while. And also we've lobbied hard through the local resilience forum that I mentioned earlier to try and secure, and we have secured, improved testing facilities for care workers and others, initially at Teesside Park, but then last week for the first time at Redcar Racecourse. The fourth strand, this is about preparing for recovery. My apologies, just getting a phone call come through, just switch that off. Preparing for recovery. We are now, the Borough Emergency Centre is focusing with all directorates on their plans for the future, and each group, each directorate is coming to producing their plans on what future services might look like, how we might operate going forward, but trying to lock in some of the benefits that we have seen. So it has been a council policy for many years to encourage people to work from home. That's happening on a grand scale. How can we help to make sure that's locked down, which reduces carbon emissions, traffic congestion on the roads and so on. We're putting plans in place to ensure our workplaces are safe for staff as and when they return, whether it's coming into the office from time to time. We're also doing more to work with the voluntary and community sector. We need to prepare for that to ensure the sector is very, very strong as we come out of this crisis, because more and more people will need support. Part of the work at the moment with each directorate is also looking at successive government announcements on the release of lockdown. As announcements get made, we have to prepare and plan for those changes to be done as safely and successfully as possible. And there will be further government announcements, as we know, going forward. The final section of the strategy, this is the bit about preparing for the future more than anything. And what we're saying here is to be as resilient as possible. We could spend an awful lot of time trying to work out what we think the future might be, what it might look like, how people might behave. The reality is we don't really know that. Where we can focus our attention, and that's what this section is about, is by building resilience within our teams. Managers, leaders at all different levels. I don't just mean people at the very top. The more we can prepare people to deal with crises and continue operating successfully, it doesn't matter what the crisis is, but it puts us in a better position to be able to deal with that going forward. So we're already having presentations, certainly to some of the senior managers, to get them to think about what that kind of resilience might be. And there'll be a bit of an ongoing programme over the coming months. Right at the back of the report is a single sheet, which is the strategic response on a page. It's really just for illustrative purposes. So I'll pause there, Chair. That's a quick run through. Hopefully sets a bit of a strategic context ahead of Patrick's presentation. and I'll happily take questions if members wish.
Would anybody like to ask Rob a question? I haven't got anything on the chat at the moment, so if you just indicate if you do wish to ask Rob a question, or would you rather just go on to Patrick's presentation, because that might actually answer any questions that maybe we do have. Is that okay with everybody? If we go on to Patrick. Right, Patrick, can I invite you to come in then, and I'll mute myself again. Thank you for that, Rob.
Okay, hello everybody. Hopefully you can see the presentation there. So I'm Patrick Rice, the Corporate Director for Adults and Communities at the Council. So this presentation is going to be a bit of a joint effort. I'm going to start, then I'm going to hand over for Craig to give an update in terms of the health perspective, and then it'll be me again, and then we're going to have Victoria, Erica and Fran to do a bit, and then finish off with myself. So I do apologise, it's quite a long presentation. And even though there's a lot in it, we still probably haven't covered a quarter of what's gone on, or the different things we could talk about in terms of COVID-19 and what we've been doing, but we will try and answer any questions at the end of the presentation. I would just like to start by thanking everybody who's been involved in the response to COVID-19 in Redcar, Cleveland, in particular our staff, and then especially the care staff that we have. You know, a lot has been said about the health and care staff, but particularly I think the commissioned workforce in Redcar, Cleveland. I don't think it's any exaggeration to say they've put their own lives at risk at times to support the vulnerable in this borough. And also as well, we've got those unpaid carers as well, who have done an awful lot of work at home and to care for those vulnerable people. And it certainly has been a community-wide response to COVID-19. And hopefully we will reap the benefits from having a less of an impact of the outbreak than what we might have had otherwise. What the report highlights in particular, I think when I was going through and looking at it, is the fact that it does focus a great deal on the physical impact of COVID-19. It is a physical virus, it does affect you in physical ways, but obviously the impact of it has significant emotional and mental health and well-being impact for everybody in the borough. And I think that is something as we move forward we really need to focus as we move into hopefully controlling better the physical ramifications of the virus. We can look much more and focus more on terms of the emotional impact that it's had, you know, the trauma on staff, the impact of people being isolated, the worry that people have over loss of jobs, of catching the virus if they go out, the impact of lockdown on families and what that can do to family dynamics. So in the report as we go through, we do touch on that, but it hasn't been a particular focus. But certainly as we move forward, that is something that we will put much greater emphasis on in terms of, you know, the mental well-being impact of COVID-19. So it just very briefly in terms of the response that we've had. So the government it's been quite top down, as you would imagine, in a situation like this, with the government issuing directives more or less on a daily basis. A decision was made right at the beginning by the government that the local resilience forums across the country would manage the outbreak and the overall response. And we're part of a Cleveland local resilience forum, and that forum is there to deal with any emergency situation. It has a major incident plan, and we are a key component of the resilience forum, as are all of the blue light services and all of the councils and a range of other statutory partners. And the overall response, often when the government are wanting assurance about what is going on locally, it's through the local resilience forum. At one point it was having 3 calls a day, 7 days a week. It's now down to calls 2 days a week as the pandemic has been managed to a degree. But that is where often as a lot of things are undertaken collectively, and we work together, and there's certainly been a lot of work, which I'll show on the next slide, that the Resilience Forum has done. Sitting underneath that, we've got the Tees Health and Care Partnership, which again, let's explain a little bit more later. And I think it's quite interesting that I was on a call with a lot of national colleagues a couple of days ago, and they were talking about in some parts of the country, this outbreak had created or caused some additional tensions between health and social care. And what I would say, certainly locally across Tees, that I don't think this, you know, we do sometimes have our disagreements or debates with our health partners, but as far as the overall COVID-19 response has been done, it has been absolutely everyone working together. People put the best interests of the residents of the borough at heart. No one could claim otherwise. And I think the partnership has been a real strength of the work that has gone on. And then obviously we have the council response, which Rob has mentioned. And then this paper here, this presentation, is really focusing on what's gone on within our directorate. Obviously, our directorate is very broad and has a number of facets, and every single aspect of our directorate has been impacted one way or the other by COVID-19. So in terms of the local resilience forum then, as I said, the resilience forum at the moment has moved into what is called the recovery phase, same as the council, as was mentioned in Rob's report. But certainly I think as far as adult social care is concerned, it doesn't feel like that, probably for public health as well, that we are not in recovery yet. We are still dealing with the immediate crisis. But there gives you a bit about the structure of what happens in terms of the LRF. And just to give you an idea, there are some of the things that have been really important that the LRF was dealing with early doors. So this is where, as a Tees body, we were working together. There was a lot of work done with the coroner's office to make sure we had appropriate body storage facilities. That was an absolutely critical concern early doors. Was about body storage. The LRF has dealt with the PPE distribution. So often when you might have heard on the news that the government announced there's got to be some PPE distribution across the country that would come to social care, that was going through the LRF. So that would go to a big warehouse in Middlesbrough, and then through the warehouse it would then be distributed to the local authorities and to anybody else who needed that PPE. And then also the local testing sites, which we've had military support with. So the military are part of the LRF. So again, through the LRF and our working in partnership, that's how we've managed to arrange the testing sites, the mobile testing sites that we've had in Cleveland. And the main issue that we deal with in terms of the LRF at the moment, it's really around situational awareness. So really trying to understand what's going on in terms of police reports, in terms of breaches of lockdown, what's happening in terms of comms. Are there any emerging national issues that we need to be aware of? But it feels like we're out of the crisis mode in the LRF, but very much an oversight role at the moment, with the local agencies managing their own recovery plans. But the government still sees the LRF as being the critical linchpin in terms of what is going on and managing the response. So the next bit I thought I would do is just give a very brief update in terms of the timeline of COVID-19. It's always very, when you're sitting in a situation, you might think, gosh, why did we do that? But it's always, you know, you make decisions done with the best information that you had at the time. So I just thought it was useful just to very briefly go through some of the key events which have impacted in terms of this department through COVID-19. And as I say, I won't go through all that are listed there. One of the first things that we might talk about later in terms of people being at risk of homeless, on the 18th of March, the government announced that there was going to be a ban on new housing evictions. And then on the 19th of March, we opened up our Borough Emergency Centre, which Rob mentioned earlier. And then on the 19th of March, the council decided to close a number of services in relation to the fact that social distancing had been announced in early March. In terms of then what happened next, the 19th of March, I think, was it like a watershed, a critical day for adult social care. So on the 19th of March, the government published an ethical framework for adult social care. So I think at this stage, the government felt that we were going to end up having a very much worse situation than what we ultimately had. So they set out this ethical framework for adult social care departments, basically reminding us who work in adult social care of our ethical duties, around trying to minimise harm, treating people with respect, showing reasonableness in the judgments that we were making. And I think that probably was no coincidence. That came out of the same day as the hospital discharge arrangements. So on the 19th of March, the government published a 42-page document which set out for the NHS how they were to free hospital capacity. And this was a critical moment when the government were particularly concerned that hospitals would be overwhelmed. I remember that phrase being used an awful lot at the time. And the government made a commitment to free up 30,000 existing NHS beds, and 15,000 of those 30,000 beds would be freed up by this new hospital discharge arrangement, which set in motion in very, very simple terms that the fact if somebody was identified, there would be 2 ward rounds a day. And if somebody was identified that they didn't need to be in that hospital bed, they didn't need a hospital consultant to be looking after them, then a 3-hour window would be open. And in effect, within 3 hours, that person would have left the hospital. And that the government target was that 15,000 people would leave hospital beds by this 3-hour process within 7 days. Along with that guidelines, there was information which came out to say that health would fund these discharges, and that care homes would use a bed tracker facility, because it was obviously understood that a number of these people who would be discharged out of hospital would come into adult social care, whether it be at care at home or residential care. And what later on happened, there was a retrospective agreement that the actual process, there would be something called the Care Act easements, which I'll come on to, but the Care Act easements actually allowed this speedy discharge of people into the community. Some didn't need social care, probably the majority didn't, but a significant proportion of those people needed adult social care, and they were released either at home or into a care setting. And at this stage, there was no testing. People were released from hospital. 15,000 people was the target within 7 days, with no testing being undertaken as to whether those people still had COVID-19. Then, as you can see, there's other information there about the shielding hub that the council set up. We were particularly worried about the fact that people were being released into our care settings without being tested for COVID-19. So we did actually contact our local hospital trust to ask them if they would test people who had been admitted to our care settings. They declined, but this isn't in any way criticism of the South East hospitals at all. They were, as they said to us, they were only following what was the government guidance at the time. And my understanding was the guidance as it was because there was a lack of testing capabilities at that point in time. Another interesting thing happened in middle of March, particularly on the 23rd of March. I think the government as well were particularly concerned that there would be shortages of care at home capacity to support people who had needs, but actually the opposite happened. We suddenly had a lot of capacity in the care at home market, because a number of families were concerned that their elderly relative would be looked after somebody or a number of carers, that the risk of infection, and also a number of family members by this point would have been socially distancing or furloughed or working from home. So a significant proportion of care packages were cancelled, care at home packages. I don't think anybody or very few people came out of residential care to go home and be supported by their families, but a number of care at home packages were cancelled, which suddenly created a number of surplus hours in the care market, which again, I'll come on later in terms of the money as to the conundrum that then caused for us. Also, the 23rd of March, we introduced a new framework in terms of regular liaison with care providers. We went to every care provider and agreed with them how, from daily onwards, in terms of how we would communicate with them over infections, PPE issues, and whatever else it might be in terms of the COVID. So our commissioning team have been liaising constantly with our care providers over what has been going on. And then on the 27th of March, again, just about testing. So testing did start to be ramped up on the 27th of March, and there was an announcement made by the government that certain people working in hospitals, in particular, key NHS hospital staff, would be eligible for testing. So Although we were asking for testing for our care residents, at this point in time when we were asking, actually a number of frontline NHS staff weren't being tested either. Sorry, just taking a breath. So on the 30th of March, again, as Rob has mentioned, we opened up our shielding hub, which and our dedicated phone line and email address for supporting local residents. That did have a real impact initially, and we got a lot of people coming forward with queries, a lot of people coming forward looking to volunteer, but that has significantly tailed off after the first couple of weeks. On the 31st of March, the Coronavirus Act came into law, and it introduced something called the Care Act easements. And this was particularly important going back to those hospital discharges, because what it did do was it relaxed the Care Act duties that the council was under. Again, the understanding was at this stage of the pandemic that there might be a significant shortage of adult social care support. So under the Care Act, we have a duty to meet eligible care needs. The Care Act easements removed that eligibility requirement until the easements are relaxed or removed. And instead, we have a power to meet needs only where failure to do so would impact on someone's human rights. In other words, as the guidance says, we were given the authority to prioritise care. So if people needed critical social care, we would offer them that, perhaps at the expense of people whose social care might deem to be non-life threatening at that particular moment in time. And if we were ever at any stage going to enact those easements, we would have to publish the reasons why and report it to government. I think around about half a dozen councils have enacted the easements, but because of things like we actually ended up not a shortage of domiciliary care support, we actually ended up with surplus hours. We've never come anywhere near having to enact those easements, but those people who have been moved through this process out of hospital, they have been moved without the usual social work interventions taking place within the hospital setting, just because of the 3-hour window that we were working in. Then on to the 2nd of April, I'm trying not to labour this point, but new guidance issued by the government about care home admissions from hospital, and that's set out because I think there had been some comeback, and that did set out that actually it confirmed that a negative test was not required to allow an admission, and the government into a care home. So the government view was if proper protocols were followed in relation to quarantining and appropriate PPE was one, there was no reason why COVID positive patients should not be moved from hospital into residential care. And also at this time, the government confirmed that if there was a COVID outbreak in a care home, no more than 5 residents would be tested to confirm the outbreak. So at this stage, the plan wasn't to test everybody in a care home. It was only to test a proportionate number to try and understand, was there an outbreak? And if there was an outbreak and people were symptomatic, those symptomatic residents were to be isolated. The theory was, or the view at that time was, there was no need to test everybody because you're going to be isolating them anyway. The 15th of April, there was a new national plan for adult social care came in, which at this stage reversed the bit about it only being for 5 residents, and it said that anybody who was symptomatic in a care home would be tested, but it was only symptomatic residents only who would be tested, and care home admissions from hospital were to be tested. So about a month after the initial view about moving people out of hospital, at this stage the testing capabilities were there, so it's confirmed that from 15th of April onward, care home admissions would be tested, but people would still be moved into a care setting before the test results were known, with the view was that they would be isolated, quarantined in effect, until the test results came back. And then there's some other bits there about when, and you can see as the government testing capabilities expanded, that then they continually expanded the opportunities for more and more people to be tested. Right, on to the next one, on to the next slide. So I think there's some important, the next key important date I think there in terms of us in social care was on the 1st of May. The government announced, I'm sure Craig will cover some of this, it's in some of the later slides anyway, about the new enhanced offer that primary and community services were giving to care homes, because by this stage it's become understood how critical the scenario was in care homes. Some guidance was published around the health and wellbeing of the adult social care workforce. And then on the 15th of May, more support, government support was given to residential care with the announcement of the Infection Control Fund, a £600 million fund. Roughly £1.8 million worth of that fund came straight from Cleveland. And I'll talk a little bit about that later on in terms of what that means for our care homes. Then we had the pilot for test and trace was launched or announced on the 22nd of May. And then we had our first mobile testing site in Redcar on the 1st of June. And Teesside Park, because Teesside Park is now opening up for business in terms of McDonald's opening. And I think some shops are going to open soon. Teesside Park is no longer going to be used as a mobile testing site, and that was the key mobile testing site on Teesside. So as you may know already, there's been additional days put in for Redcar Racecourse this week, and until a new testing site is identified somewhere in the centre of Teesside, I imagine there will be additional days at Redcar Racecourse. So that is it, I think, in terms of some of the timeline, but I think that's important when we go on and look at some of the other slides in terms of the graphs and the dates when things occurred in terms of that background. So very, very briefly, I know I'm going to end up just talking all day. So in terms, as I said earlier, there's been great work in between the health and social care setting. You know, some of it is being, we've had government directives that haven't always helped us, but at times we have, as a local system, have managed to work around it. So I've already mentioned that we now have infection prevention and control training, which has been organised through our local CCG. Every care home now on Teesside has had that training by video link, and now the trainers are going around our care homes, giving that training face to face in a safe way. There has been significant mutual aid between us. I can particularly remember a day when our CCG gave us 6,500, offered us 6,500 protective face masks because we were running desperately short. So again, there's been great work in between us, and as well at the hospital, even though we've had issues over the overall rollout of testing, of getting people tested, the hospital did have, when it was testing its staff, it did have some spare capacity, and so did North East Hospital, and both hospitals offered their spare capacity in terms of their local testing to partners within the LRF, which was hugely appreciated. There's going to be some information come out very shortly for all members about the enhanced offer to care homes that our local primary care networks will be offering, which will be significant improvement in terms of step forward in terms of the offer. Our mental health trust have been providing virtual clinics to help carers and care workers support those lacking capacity. I think one thing that often gets forgotten is that a lot of those in adult social care don't have capacity around some of the decisions that are being made. So should someone with dementia be swab tested? You know, it's an intrusive test to test them for COVID-19. How are we socially isolating or quarantining people with dementia in the rooms? And certainly our mental health provider have provided a lot of information and support to our care settings in terms of helping to manage those who have no understanding of what's happening to them, to manage that person. And again, through our CCG, we had one particular issue where we needed some nursing support in their care home, and our CCG absolutely stepped up to the mark and provided some emergency nursing support. And thankfully, because I'm getting tired now, my voice, I'm going to stop now and hand over to Craig.
Thanks, Patrick.
Just before you pass over to Craig, Patrick, thank you for that. And thank you, Craig, so much. It's lovely to hear about the collaboration that's going on between the two different units, because to be quite honest, to get over this, the more we can work together, I think the better and the quicker it's going to be. So thank you very much for that, Patrick. Come back to you later. And Hello, Craig. Come and join us.
Thanks, Chair. Okay, so in terms of the health response, I've got a couple of slides that I'd like to take you through, but just before we start, really, if I could just reiterate some of Patrick's comments, first of all, by thanking all of the frontline health and care workers out there who really have gone above and beyond, putting their own lives on the line to help with the response to COVID, but also to thank Patrick and his team and the broader council for the partnership working that we've seen over the last 3 months in trying to help the T system respond to this pandemic. It's really been a remarkable feat to see everybody come together and work in partnership the way we have. So thank you for that. What I've tried to do, rather than provide you with lots of slides setting out all of the individual actions that we've undertaken as a CCG and a health system over the last 12 weeks or so, I've just provided a few high-level examples of some of the key things that we did. We did look to pull together a more detailed timeline. I got to 20 slides and thought that was enough, really. So if we synthesize some of that down to the key themes, which we've got here, and I'll try and talk you through some of those. So by way of an example of some of the key things that have happened, during March, when we first started to feel the impact of the pandemic, there was a lot of work undertaken within the local health service to undertake stress testing and understand what the capacity of the local system was. So how many hospital beds did we have? How many could we make available with oxygen? What could we do in terms of changing the way services are delivered to support more people being seen and prioritising care for those with the greatest level of need? We also looked at some of the command and control arrangements that we need to implement, and if the health system went into crisis, how would we make sure that we got the right support out there, that we understood what was happening, that we could get the right patients to the right services and the right support into those services as well. Similar to the council, we undertook a lot of work to make sure that our own staff were prepared and protected. So we instructed all our staff to work from home. We implemented virtual working arrangements. We adopted things like this, the use of Microsoft Teams, so that we could continue to deliver our core and statutory functions, but with our staff being safe in their own homes wherever possible. We spent a lot of time and effort looking to develop system capacity, and what I mean by that is making sure that we had appropriate capacity in the hospital, but also outside of the hospitals as well. So there's a lot of work undertaken with colleagues in social care around the discharge guidance that Patrick's already mentioned, making sure that we had beds available in the hospital so that when patients needed admitting with signs and symptoms of COVID, there was capacity there for them to be admitted into, but also the right support outside of the hospital so that patients who didn't need to be in a hospital setting could return home as quickly as possible, and if not home, then to a place of safety where they could be cared for. There was a lot of work undertaken at that stage as well to understand the oxygen provision and critical care capacity across our local hospitals, not just at James Cook, but also with North Tees and Hartlepool Foundation Trust and over in County Durham and Darlington, in particular down to Memorial Hospital, to make sure that we could make as much bed capacity available with oxygen supplies and critical care capacity as possible, because we were able to learn from some of the experiences around the rest of Europe, where perhaps the pandemic hit them first. So we were able to watch, learn from that, and then implement actions ourselves to make sure that we didn't find ourselves in a position where demand for these types of beds and oxygen provision outstripped the capacity that we had available. We also started to work at that point on communications with our staff and broader partners as well, so trying to prepare people for what might be to come and some of the key actions that would need to be taken, and how we would look to communicate not only out with the public but with other organisations in the health and care setting, so they knew what to expect from us and we had a good understanding of what we could expect from them. Moving into April, April was very much around making sure that we'd implemented some of the key responses that we were looking to put in place. So we made changes within the primary care setting. We introduced things like the hot clinics, so that individuals who had suspected COVID had a safe place to access treatment and be seen, and we wouldn't be putting members of the public who didn't have signs and symptoms of COVID at risk. Again, we continue to work on the discharge from hospital pathways to make sure that we could continue to keep beds available and free within the hospital environment. And some of that included looking at how we used our community hospitals differently. So we went through a process of redesigning the 2 community hospitals across the south of Tees, so that we had one that primarily focused on managing patients with COVID and one that focused on managing those patients without COVID, therefore reducing the risk to cross-contamination between the different streams. And actually what we did is turned Redcar Primary Care Hospital into the COVID site and used East Cleveland for the non-COVID patients. We looked at how the community services that we have out across Redcar and Cleveland and Middlesbrough could be used differently, and some of those services we redeployed the staff to provide support in the hospital setting. So individuals who were trained or capable of supporting on critical care units or patients who required oxygen provision were recalled back into the hospital setting. Others were redeployed to provide support similar to what Patrick's highlighted around providing additional support into care homes. And we also worked on staff testing, and staff testing was extremely challenging, as has been the whole testing regime, but we've worked together in partnership with LRF partners to make sure that as testing capacity came online, we were able to maximise that, not just within the health service, but across the whole care sector. And then more recently, making sure that we were able to test as many members of the public as possible who have the signs and symptoms. Moving into May, again, Patrick's already touched on some of this, but we worked through an enhanced offer to care homes support. So that included looking at new clinical leads to care homes, the offer of access to mutual aid, primary and community mutual aid. So if there was nursing shortages, we were looking to see if we could move our community services staff around to provide input into care homes, to provide that backup or contingency where there were issues, shortages, or even outbreaks in facilities. And we've also started to think during May about the second phase response. So everything we've talked through so far has been about the first phase, so the initial impact of the pandemic. But our thinking's now starting to move to what happens next. So we're starting to come out of the initial peak. And we've got a lot of individuals at home who are waiting for routine treatments. We've got people who've not accessed healthcare for a period of time, and they've put off speaking to their GP or doctor with long-term conditions or other ailments, complaints that now need to be managed, and these patients need to be seen. So how are we going to go about doing that whilst keeping them safe and our staff safe? So we started to make some of those plans. We started to make those plans in May. We're further developing them in April, and we're looking to establish what the new norms will be, because COVID-19 is going to be with us for some time, and to return to what was the norm of 4, 5, 6 months ago is unlikely in the medium term. So we need to think now about what will the new norm be, how many operations can we undertake, how do we continue to manage patients with COVID whilst trying to do some of the routine work that we would have otherwise picked up. Patrick, if you're able to flick forward for me. Thank you. Okay, so in terms of some of the action that we undertook early on to build capacity in the health system, I thought it was important to try and demonstrate to you what that's meant in terms of a number of people being admitted into James Cook Hospital, South Tees Hospitals Foundation Trust. And the best way of doing that really was to look at the number of patients reported on the daily bed status. There's a census undertaken in the hospital at 8 AM every day, and those figures are published. And what I've tried to demonstrate on the charts on your screen is how the impact of COVID came in, the proportion of patients in beds, and how we've passed through the peak of patients occupying a hospital bed with COVID or COVID symptoms during April. And as we've moved through May and into the very beginning of June, the number of people occupying a hospital bed with COVID has subsided significantly. And what you've seen then is non-COVID patients starting to come back into the system. So that's as we've tried to get more urgent cases into the hospital and through, and people who are requiring planned interventions, some of those starting to feed back in as well. So that's just to give you an illustrative example really of how the hospital capacity has been split whilst we went through the initial phase of the pandemic. Patrick, if you can click forward for me. Then what I've gone on to do is try and give you a feel for how how the hospital in particular has coped in terms of the number of individuals requiring access to oxygen. So you can see that as we move through that initial peak of the pandemic, around the second week of April, there was a lot of individuals admitted in hospital beds requiring oxygen, both mechanically ventilated, non-invasive oxygen, and piped oxygen. But you can see that as we've moved towards the beginning of June, those numbers have decreased dramatically. And what that means is we've got less people coming into hospital requiring access to this kind of treatment. We've been able to maintain our capacity, and we're now starting to get to a point where there is room within the hospital to recommence some of the more routine treatments and procedures that we would have undertaken. Patrick, if we could skip forward. Okay, so during the first phase of the pandemic and the first phase of the health response, what have we learned? Well, we've taken a lot from our response. The digital technologies has been a really big advancement for us. So we've been able to continue to undertake lots of assessments, both in primary care and what would have traditionally been done in a hospital setting through outpatients, through using non-face-to-face technologies or web chats. So things like the use of the Teams technology that we're using now, there are hospital-based systems that can offer a similar interface for patients to have a consultation with a consultant, talk through their condition, and obviously then receive some advice or guidance or diagnostic on what the complaint may be and what the next course of treatment or action might be. Now, that's not applicable that's not relevant for all treatments and all conditions, but a significant number of specialties can undertake their business this way, therefore reducing the need for patients to travel to hospital. And if we can keep people out of hospital at the moment, that feels like the right thing to do. We know that there are numbers of hospital-acquired infections taking place at the moment, so supporting staff and patients to keep away from a hospital environment intuitively feels like the right thing to do. We've made great use of digital technologies in training and supporting specifically our care homes with training around things like PPE. So we've been able to undertake training with pretty much all of the care homes, either face-to-face or through video consultations, to support them in understanding when they should use PPE, how they should use it, whether they're wearing it right, if the fit's right, etc. And that's been great because it reduces the risk of cross-infection. But it also allows us to be more efficient with the use of our time, and we've got limited resources in terms of the experts who can go out and do some of this training. So if we can do some of it through video consultation and cut down on things like travel time, that's brilliant. But also we can record our videos of the training session so people can go back and double check at a later date if they've got any further queries on how to follow some of the procedures. We've also made great use of things like SharePoints for information sharing, so working across different health and care partners. We've been able to make better use of some of the technology to share information around our planning, how we're responding to various elements of the pandemic, and the processes that we've put in place. So that's worked really well. And we've also used this kind of technology, Microsoft Teams, Zoom, and other digital platforms to help us conduct our business, but without the need for staff to meet face-to-face, and therefore again supporting social distancing and reducing the likelihood of cross-infection. In terms of partnership working, our partnership working has been brilliant, really. We've seen examples of it at an operational level with things like PPE, supporting bed capacity, hospital floor, testing, care home support, how we've supported shielded patients with partners from right across the local resilience forum coming together and working without boundaries, really. We've been able to park issues like the financial constraints that some of the organisations have, health in particular, and we've been able to access resources that have been made available nationally to get on and do the right things and do them in a timely manner. We've also worked together on some of the strategic responses we've put in place. So in terms of how we've worked with the hospitals to make sure that we've got a planned approach to changing the way outpatients works, perhaps. We've been able to work across a bigger number of health organisations, hospitals across the northeast to look at doing things in a collaborative way and at the same time, so we don't cause confusion with the public or create pressures in one organisation at the expense of another. So that's been really good. We've improved our communications, and the partnership communications have been really good. We've been able to get correspondence out to our care homes, working with people like Patrick to get a single response or single letter out that details the offer from social care, from health, and from the primary care networks. So that's been really good. Hopefully that's helped ensure that we've got consistent messages and we're not inundating some of our service providers with lots of different correspondence, instructions and offers. We can keep everything together in a nice tight package so that they can understand what is available to them. And I've already touched on some of the reduction and removal of the organisational barriers, in particular the financial constraints that we've all been working with. All of that has been put to one side as we've worked through the first phase of the response to the pandemic. In terms of staffing, I think one of the key learning points for me is just how adaptable and flexible all of our staff have been, both within the health service but also within the care setting. And most of our staff have been absolutely open to new ways of working, whether that's in how they go about delivering services or when they've been asked to undertake new or different roles. They've all embraced it and attacked it with vigour, which is great. There's been a real willingness to provide support across the whole system, the health and care system, and across the different organisations. And I know that there's individuals within my team that have been supporting on the social care agenda, and vice versa. Patrick's got team members who've been absolutely supporting with health issues and the health agenda, which has been great. And I think the final thing on staffing is our staff have been incredibly resilient, and to help with that, we've had to look at arrangements around pastoral support, virtual drop-ins, team building, developing shared identity, because we have been working in different ways across different organisations. But where we've been able to do that and put that in place, our staff have showed great resilience, and hopefully that will continue, but it is something we need to think about, because we can't expect our staff to continue to work the way they have under the pace and pressure that they've been working for the longer term. So that's something to be mindful of as we move forward. In terms of communications, we've had a series of internal and external communications going out at the beginning of the pandemic, very much daily, making sure that partners were briefed in terms of what was happening, what were the pressures in the health service, how can they help us respond, how can we help them to respond to their pressures. More recently, some of those communications have slowed because we've started to get to grips. We've passed the peak, and we're starting to come through the other side of it now. So we are communicating less frequently, but we are still meeting with all of our partners through what's referred to as the TEAS ICP COVID group on a twice weekly basis, and we expect that to continue for the foreseeable future. Patrick, if you could skip forward for me. Thank you. This is just a slide that I wanted to bring in just to keep everybody focused really on the size of the ask that the health and care system is facing at the moment. So whilst we've started to come through the first wave of the pandemic and the initial hit in terms of the numbers of people being infected and admissions to hospital, and sadly the tragic number of deaths that we've experienced, that isn't the end of the pandemic. What we're expecting to see is further waves that will come in, so waves that will impact on individuals who've not accessed treatments because they couldn't, because services had to be paused whilst we dealt with the immediate urgent response. The flow of patients that would have come in that haven't been able to, who are having a long-term condition management. So some of our more elderly and frail population who've been self-isolating and shielded for a period of up to 12 weeks, who potentially haven't had the full range of care and support that they would have otherwise accessed. But also those individuals who have been working to respond to the pandemic, who have been working at full pelt for a period of 2, 3, possibly up to 4 months, who are in danger of suffering burnout, psychic trauma, and developing mental illness themselves because of some of the things that they've seen and experienced whilst responding to the pandemic. So it's great that we're starting to come out this first wave, this first phase, but there's some very different implications for the health and care system, and we need to be thinking now, as we already have been, about how we respond to that and how we offer support not only to the public, our population, but also our staff. Patrick, if you could just flip forward for me. So where are we now? Well, we're moving into what's referred to as the phase 2 of the health response, which is consolidation. That phase is expected to last between May and July, and we're primarily focusing on developing our recovery plans, not only at an individual organisational level, but how do we bring those together at what we're calling a system level across the Tees Valley, so that we can make sure that we've got equitable access to the various services that are available, and we don't create unnecessary or undue pressure in any one bit of the system as we start to standardise and look at what the new norms are going to become. We've got a real focus on delivery of safe services, not only for patients but also for staff, because we should be mindful that we need to continue to provide a response to COVID patients whilst trying to reinstate non-COVID pathways of care. We're starting to plan for the future in terms of what next with COVID. So will there be a future spike? Will it be a further spike, a further wave? What will happen when we hit the winter? Do we expect to see a resurgence of COVID under winter pressures? Do we think there'll be an impact of seasonal flu and COVID? We're just starting to model what that might look like, and considering what worst case scenarios might be, what likely case scenarios might be, and what that would mean for both health and care services. And importantly, we're starting to work through understanding the impact of phase 1. So what is the impact of delayed presentations to primary care? What does this mean for people who've had long-term or have long-term conditions who are managing at home at the moment? What does it mean in terms of people who've not attended their routine screening, or for young children who've not had their immunisations? So how do we recover some of that position? What do we need to be doing? What's the impact on routine non-COVID hospital pathways? So I've already touched on outpatients. What are the waiting times like in a hospital now? We know that prior to COVID, we were working to make sure that all patients were seen within 18 weeks. Given that we've been working through this phase of COVID for around 12 weeks now, it's reasonable to assume that waiting times would have gone up by at least that period of time. What's the impact on our staff? So we do not want to run the risk of our staff burning out. We know that we will have increasing pressures as we move into the winter. We're in July now. From a health perspective, the winter starts in September, so we're in June now. I'm wishing the months away. The winter planning would normally start June, July time. Winter starts officially in the health service in September, so we haven't got a lot of time. So we need to make sure that our staff are prepared, ready, rested, ready to go again before the winter continues. So we'll be doing all of that work in partnership with local authority colleagues, provider colleagues, and broader local resilience forum system partners through the Tees ICP COVID group. And I think that's just about it for my slides, Patrick. So yeah, hand back over to yourself.
Thanks, Craig. It probably feels like a marathon to everybody here, but we'll carry on. But we'll go through some of these a bit quicker, hopefully. So the next one's actually a graph I think I saw on the news this lunchtime, and this is just to give you an idea. Sorry, Craig, can you put yourself on mute? So what this graph shows is that up until COVID hit, actually deaths that were occurring across the country were lower than the national average, which helped in terms of body storage and body management. But then what you can see is there that there's been obviously excess deaths, as it's called. And what you've got there, though, which is interesting, is like the sort of whatever colour that is, orangey, reddy colour, is that those are the excess deaths that weren't related to COVID-19. So COVID-19 was not recorded on a death certificate as being a cause or a probable cause. And there's been lots of debate, as you'll see, played out around this. Is it all to do with people who weren't tested for COVID-19, or is it people who were too scared to seek medical help? But certainly there's been excess deaths in this country that haven't been related or put down as being due to COVID-19. And these are on a national scale. So then in terms of deaths by location, so this is specifically just where COVID-19 has been put down as a potential cause of death on the death certificate. And you can see there, obviously, the spike in early April. But I think what's interesting, the point I want to make is that in terms of adult social care and care homes, once you get towards end of April, the actual number of deaths that have been recorded in care homes is more or less exactly the same as the number of deaths that have been recorded in hospitals. And I think that is largely, the care homes may have been a slight delay because people in the community catch COVID-19, go into hospital. There might have been a slightly later start date for it happening in residential care. But as it's been played out nationally, is that also, I think, is the fact that in the early phases of this pandemic, there was not routine testing of people who were dying in a care home as to whether they had died because of COVID-19. So as often as been said and been reported, and so that would seem to suggest, though, that graph there, that actually more people have died in adult social care due to COVID-19 than the official statistics show. But that's all conjecture. Some information came out a couple of days ago which tried to quantify the financial impact of COVID-19 and adult social care. So this isn't just the cost to councils, a lot of this is cost that commission providers are suffering, but obviously councils are helping them with their costs. And for a 6 month period, the LGA have estimated it at £6 billion. And one of the particular interesting things that this report actually identifies is that the significant impact PPE has on it. So during this outbreak, there has been changes in terms of what type of face mask should you wear, how long can you wear the face mask for, what type of patients, are they symptomatic, not symptomatic, what type of PPE should you wear. And actually the report says, depending on one particular nuance, is do you need this particular type of face mask versus another one, actually makes £1 billion difference in terms of the cost estimates in this. So the cost of PPE, and certainly moving forward, even if the pandemic does reduce as it is at the moment, PPE and the ongoing usage of PPE, there's more businesses open, more schools open, more other settings open, the national call for PPE will only remain. This shows then in terms of COVID, in terms of the Northeast and the infection rates. Every borough, all 12 boroughs in the north of England have a higher rate of reported cases of infection than the England average. And as it's been well documented locally, Middlesbrough is one of the highest in the country. I think it's the 4th highest. And Redcar and Cleveland is somewhere in the middle in terms of the northeast, but is higher than the national average in terms of reported COVID-19 infections. And there, in terms of a graph to show you how those infections have gone, there hasn't been a dramatic spike and then a reduction, probably because the numbers are relatively low. But as you can see there, certainly there is a downward pattern from late April in terms of the reported COVID infections. But again, what this report doesn't show is the factor of testing. So obviously, as this period has gone on, it does show a slight reduction from end of April onwards in terms of the number of people being confirmed as COVID positive, but actually there has been a significant increase in the number of tests being carried out during this period. So proportionately, the number of people testing positive is significantly reducing. So looking at the overall deaths in Redcar and Cleveland, as that very graph at the beginning showed, that there have been excess deaths across the country, and no doubt in Redcar and Cleveland we have had excess deaths. The total number of deaths from the beginning of April up until the beginning of June, or a couple of days into June, there was 354 recorded deaths, and around 30% of those COVID was mentioned as a potential cause on the death certificate. And you can see there the proportion of whether those have occurred in hospitals and care homes. And so we've had 39 officially recorded deaths due to COVID-19 in our residential care settings as at the 3rd of June. So the next bit, I'm just going to talk a little bit more about residential care, because certainly as this pandemic has spread, as far as adult social care, it really has been a focus around residential care as opposed to people in a community setting. So this is a graph and a chart. This is the latest version of it, but this is something you'll have seen already in terms of the member updates. And what it does show you is that in terms of the care home outbreaks that have been, so an outbreak is where a care home was reported to Public Health England, and the North East Health Protection Team, who are part of Public Health England, go in, test, find a positive patient, and then that's classed as an outbreak. And in effect, you get one outbreak per care home. You don't then have multiple events. So Redcar and Cleveland, out of its 52 care homes, has had 16 individual care homes who have had a COVID positive case within it, and that's around about a third of the care homes. As you can see, we're the lowest by some distance locally. I did hear one planning assumption at one point which said by the end of this pandemic, you should have expected 90% of all care homes to have had an outbreak. And to be honest, when you talk about the vast majority of the population may ultimately have it, when we get to this herd situation, you think it might be hard for any care home at some stage not to have a COVID positive. But at the moment, we're at 30%, which is fabulous, and a lot of work's going in. So it's still absolutely critically important we protect those 70% of care homes that haven't had it, as well as still working with those that have had an outbreak. What is really good news, it's staggering, to be honest, the improvement that has been in this. So what this shows is looking at Teesside, so care homes in Teesside at the light blue, and Redcar and Cleveland at the dark blue added on top. This shows per day when a care home infection has been reported to Public Health England. So the first one that we had on Teesside was on the 27th of March, where we had 4 care homes that reported an outbreak. And as you can see there, as we went into mid-April, mid to late April, where all the spikes seem to be, is when we had the spike. And I say we had 2 days in late April where 6 separate care homes on Tees reported a care home infection for the first time. But since then, and as Craig has mentioned, and our brief mentioned as well, there has been a significant amount of work. There's been work done all the way through, don't get me wrong, but there has been a significant ramping up of testing, of PPE, of clinical support, going into care settings. And as we've understood the virus better, the number of new infections has significantly reduced. So up until a couple of days ago, we'd got a fortnight without a care home on Teesside, a new care home which hadn't had COVID before, reporting an outbreak. Unfortunately, the weekend we had 3 care homes on Teesside that reported one of them being in Redcar and Cleveland. But even so, the overall downward trajectory in care home new infections is significant, and shows that the work that is being done at the moment is having a significant difference in terms of keeping the residents in care homes safe. One of the things that is talked about a lot nationally, certainly in the world of adult social care, and will continue to be, is about occupancy levels in residential care and the sustainability of the residential care sector. So at the moment, this graph probably isn't the easiest one to read, but what it shows is there's been roughly a 3% drop in occupied beds in our care homes, which equates to roughly around about 50 beds. Now, care homes are funded when the local authority funds its residents. Some people pay privately, the health authority pay for some, and we pay per bed. So for each, we don't pay a care home to run a care home, we pay for each individual person that is there. So when they have empty beds, the care settings are not getting paid for those empty beds. And at the moment, those under occupancy rates belie the fact that some care homes have had no movement in occupancy, some have had significant. We've got one care home in the borough, quite a large one, running at 30% occupancy at the moment, because it's been particularly hit hard by COVID. So that there is some nuances there hidden within the overall graph, and also in that chart is, if you remember, I mentioned earlier about this 3-hour movement of people out of hospital into care homes under the emergency COVID legislation, which the health service, the CCG, are currently funding. In Redcar and Cleveland at the moment, there's 130 people since those changes were brought in the middle of March, that we have moved into a residential care setting. And those people, residents post-COVID, may not stay in residential care. They may, some will, some hopefully won't, and we'll be able to go back home. So it could become even more acute under occupancy levels, and particularly if those remaining 70% of care homes who haven't had a COVID outbreak get one and see, unfortunately, some deaths, then under occupancy levels may go up. So under occupancy, the sustainability of residential care is going to be a big issue moving forward. By the opposite token, though, we may have a number of people being cared for at home by relatives. And again, as furlough and everything else eases and people go back to work, I do feel that we will suddenly get some family members who've been looking after relatives at home suddenly come out and say, I've got to go back to work. My mum, she's worsened over the last couple of months. She needs residential care. So we may see an increased residential care admissions. By the same token, though, there might be some people too frightened to go into residential care, having seen all the press stories about infections. So the future of residential care is a very, very difficult one to predict at this moment in time. So what are we doing to support the care sector? As you'll be aware, we have had 2 tranches of funding that have come into the council. So we've done a raft of things. We have, particularly because we knew that the difficulties with PPE, and each provider, it's their responsibility to supply their own. But we purchased probably just short of £250,000 of the PPE ourselves that we managed to supply and have given it out free to providers. And we've also, as I mentioned earlier, the LRF distributions that come down from the government with the PPE, we have then handed that on to the providers as well. So they've had significant amounts of free PPE from us, but will be purchasing their own. And as that earlier LGA chart showed, that actually PPE is a significant cost of the cost of care now. On the 23rd of March, we agreed to pay our domiciliary care providers the average amount of money that we were paying them previously, paid them for the average amount of hours, plus 5%. You may remember earlier on in the slide, we talked about how some care packages had been handed back in, so care staff weren't working. Some of those care staff would have been on zero-based hours. So to make sure we protect people's wages, managed to retain staff in the care sector, we had a bit like our own furlough scheme, where we paid our care providers based on the average number of hours that they were providing to us pre-COVID, even though they were now providing to us less, or some were providing less, on the basis that they still paid those care workers who were doing those hours before. So we paid them the normal hours plus 5% enhancement for all of the other costs that they would have due to COVID. That went to the same for people who receive a direct payment, so they could afford to pay their PAs more money to supply their own personal protective equipment, and also residential care, we paid them 5% extra on top as well. Then on the 20th of April, the residential care, we then increased the offer to residential care, so now included self-funders. So we paid residential care providers 5% on top for people who were self-funding in their care, because there was a risk that the residential care companies might argue, start charging self-funders for the cost of the PPE that's being provided for their care. So we upped our offer, and then on the 18th of May we upped it further again to 10% for residential care. So now we pay residential care providers their normal fee for a resident plus 10%. And the NHS, so there's a number of people in residential care who we commission on behalf of the NHS, and when we've paid extra 5%, 10%, the NHS have also matched it for the residents in care settings. And sorry, we'll just go back and then just mention that infection control fund. So that infection control fund was just announced a few weeks ago, where that is money for care homes to specifically spend on managing infections in the care setting. We are making lump sum payments to residential care using that money. That's the directive from the government, and it's going to be paid in 2 lots. A lot we're paying this week, and a lot we're going to pay in about 2 months' time when the second lot of the money comes into us. And that works out at roughly £930 per bed. So not per resident. So if a care home has 20 beds, they'll get 20 lots of £930 to help them manage infections. And they have to submit a return to justify how they spend that money. So as an example might be, if a care provider runs 2 care homes in the borough, this money is then to allow them to employ some extra staff. So staff aren't transferring from one home to the other on different shifts for fear of risk of them taking an infection from one care home and passing it on into another. So impact on other areas, we're going to start off with adult social care, and I'm going to shut up again, and Victoria's going to come in at this stage to give a little bit more detail on what's been going on in adult services.
Thanks, Patrick. So in terms of support to providers, in addition to everything that Patrick has set out, the support to care providers has been very robust, included a single line of communication, as you saw at the beginning of the presentation, and that has been to provide support around PPE guidance from Public Health England and interpreting that, which has been very challenging for care providers, and we've really provided a tailored approach. So at one point we decided that we would contact everybody daily and make sure that they had daily contact with us, but then we listened to care providers because they said that actually that was too much for them to cope with and they had an awful lot going on. So we tailored that understandably to meet their needs, and we flex that support whenever it's appropriate and required to do so. So the support we provide through our commissioning team enables them to keep delivering their service. And I have to say, echoing everything that Patrick and Craig have said, the dedication and resilience that our care providers have shown during this period is outstanding, and they've worked so hard to keep infection under control. We've seen great examples of this in Redcar and Cleveland, as others will have done nationally. So in addition to interpreting guidelines, we've coordinated and purchased, as Patrick has said, PPE. We've delivered it ourselves in conjunction with our council colleagues in fleet management, not just to care providers, residential care, nursing care and domiciliary care, but also to people who are in receipt of a direct payment and informal carers who are in our communities. And we've delivered over 330 items of PPE, 330,000 items of PPE and 1,400 litres of hand sanitizer, working with our LRF colleagues as well to coordinate that. And sometimes the support that we offer to care providers would just be to listen. We cannot underestimate the emotional impact, as Craig set out earlier, on the care workforce and the health workforce. And those 140 deaths in our care homes since March definitely will have taken a toll in terms of the trauma and the emotional impact on the care workforce. In terms of our own council workforce, we've got 50% of our in-house direct care staff shielding. So those are staff members who are employed in Medigate and our reablement and independence teams, Jervo and our day services. And we're working with HR and our occupational health colleagues to support and facilitate a return to work where we can and where it's safe to do so for those individuals. Our social work teams, safeguarding and occupational therapy teams are all fully operational, and they're doing assessments and reviews in a different way, being creative, maximising the use of digital technology and platforms, and supporting our care homes in ways that we haven't done previously, being innovative. We've given tablets to our care homes to promote family contact for residents who are in those care homes and experiencing lockdown just like the rest of us. And in terms of supporting the workforce, we have most of our workforce working from home currently, and that connectedness and support has been critical for our workforce. And we've heard other examples of this, but we have delivered electronically and to people's homes where necessary for our workforce a weekly newsletter, which has included key information about resources, support available, emotional wellbeing offer and support that's been delivered by TUV, our mental health trust, explaining temporary procedures in this newsletter, as well as through key meetings, team meetings via Teams. And issuing guidance around best practice during this period and ensuring management support and oversight is in place at this time. In terms of supporting the hospital, we've mobilised our workforce, particularly social workers, to support 7-day discharge from hospital in line with the current South Tees offer that Middlesbrough run out on our behalf for hospital discharge. We will have our own hospital discharge service from the 1st of July, so that work is still going on, and that will enable us to offer a consistent approach to acute and community hospital discharge for Redcar and Cleveland residents going forward. In terms of our home adaptations, unfortunately, Disabled Facilities Grant funded home adaptations have been put on hold due to the lockdown. Excuse me. We've got 8 currently that are on hold, and we're providing alternative support where this is required. And it's one of the unforeseen, unexpected, but unfortunately one of the realities to the pandemic and the lockdown that ensued. Care Act easements, Patrick has touched on these previously. We've developed a framework to benchmark ourselves against in line with the guidance, and to confirm again, we've not enacted any easements and we don't intend to enact any easements, but we are at stage 2 in line with the guidance because of our temporary closure of the day services and our reduced reablement capacity due to staff shielding. And we hope not to need to enact Care Act easements in the future, and we'll do our best not to, even if we experience a second wave, and we'll continue to keep that under review. So it is business as usual for us, and we are providing alternative support for people where it's needed, where that reduced capacity, for example, in reablement, is experienced. And the last bit really is about we're still recovering from the cyber attack, and our data reporting is now becoming available but limited, and we're using the opportunity to develop new ways of delivering what we would call performance management, making sure that we're delivering the most efficient, effective services and keeping people as safe as possible, and ensuring we're meeting all of our duties as an adult social care service. Thank you. I think, is it Fran now, Patrick? Am I handing over to?
Yeah, I'm here.
Thanks,
Hi,
Fran.
Everybody. Hello, it's Fran Anderson. OK, so just an overview of domestic abuse services. So all of the Redcar and Cleveland refuges, which we've got 1 refuge which has 12 flats in it, and we have 4 safe houses which can accommodate up to 16 women. They've all remained and continue to be full. I think we just had 1 family move into the refuge at the very beginning of all this, and the family were tested and proved to be negative, but isolated, I think, for the period of time that was recommended when they first went in. Domestic abuse support has continued to be offered by all of the providers in line with government guidance. As everybody else, I think, who's been speaking this afternoon has mentioned, you know, new ways of working, new ways of offering support to people, telephone, other virtual means, and you know, but business as usual, albeit in a different way with a different approach. Domestic abuse support services have seen a noticeable increase, understandably. I think that would be everybody's perception, but we have seen an increase in need for support, specifically around domestic violence advisors, and there's been about an approximate 50% increase in referrals to the foundation who provide our independent domestic violence advisors, from an average of 20 referrals, I think, back in February, up to 49 just last week. And as you can see by the year-on-year data, April 2019 versus April 2020, the numbers were 106 in 2019, 130 in 2020. For May, that's significantly increased again, and 93 last year, as opposed to 211 in May this year. So we're responding to that, but I have to say that is a real challenge, because you know, it's fairly difficult to recruit independent domestic violence advisors who are equipped and ready to go, but we're managing as best we can. Local and the national domestic abuse campaigns, which I'm sure you've seen some of, have been promoted right across the borough, again using many different means of communication. And as part of the national campaign, safe places for victims have been made available in some local chemists and supermarkets, which again you may have seen coverage in the media. Leanne Best, our domestic abuse coordinator, collates information on a weekly basis on all of the services, what they're prioritising, what they're still providing, and what their challenges and issues might be, and how we might support them as a local authority to continue to deliver. A number of our local domestic abuse services have applied for government funding, and we're currently awaiting some decisions, although some funding's already been awarded. And communication, I think, as everybody else, I can only echo what everybody else has said in terms of domestic abuse and many of the other services that I manage. Communication across sectors, across the region, across T's, has been really quite amazing over this period, just in terms of learning and sharing good practice. And I think what Leanne would say to you if she was here is that, you know, often, understandably so, our providers of domestic abuse services are quite competitive with each other because they all want to win the contract, and relationships aren't always as good as we'd like them to be. But that has significantly changed during this period of time, and they're much more joined up, which is brilliant, really. Could I have my next slide, Patrick, please? Thank you. Substance misuse, again, all assessments to enter treatment are now completed remotely over the telephone. But I have to say, we've kind of got a bit of a stalemate in terms of new referrals. They've stagnated, which, you know, could be a real worry, or it could be a real positive. I'm inclined to think the former, really. If face-to-face support is needed, it can still be provided, and the times are there for our provider, We Are With You, previously referred to as Add Action. So people can actually still have a face-to-face, obviously social distanced and safe one-to-one. All service users have 12 weeks of prescriptions. So previously, high risk, as we would say, clients would have supervised consumption of their substance replacement. But in view of you know, the current pandemic, everybody's been assessed individually to decide how risky it will be to give someone a block of. It tends to be, I know it says there 4 weeks of prescription, but it has actually tended to be around, you get 2 weeks worth of your prescription and then you're re-prescribed after that. And the high-risk clients do have discussions with team members to discuss their individual needs-led courses of action. And as I say, a common change has been to move people off supervised consumption. But interestingly, we haven't really seen a massive impact of that in terms of people getting their 4 weeks or their 2 week prescription and taking it all, you know, in big bulk kind of binges. Thanks, Patrick. I think it's Erica now.
Hello. Yes, I think it's me. Can you hear me? Yep. Right, so my slide. So in relation to homelessness,
At the beginning of the pandemic, national government asked for all authorities across the UK to offer accommodation to all of those in housing need. That included non-priority homeless, rough sleepers unverified, people who are not actually eligible, as in no recourse to public funds. It was catched as a help everybody, bring everybody in. We obviously, as other authority, we applied that approach, and we were able to accommodate everybody who approached us in that initial period. There's some statistics there. We had about 29 households accommodated. They were homeless, they were threatened with homelessness in those first 3 weeks of the COVID lockdown. A lot of them were as a result of family evictions, falling out with friends, family. They've been sofa surfing, so not roofless homeless, but were in a fragile housing situation before the COVID lockdown began. And understandably, well, not understandably, but unfortunately, those relationships were put under immense pressure, and it sort of forced a lot of people of sort of those relationships to break even further. We had also 5 confirmed rough sleepers, or those who have a history of rough sleeping, that were accommodated, and 10 of the 29 were people that we would have accommodated outside of COVID-19 because they would meet the statutory test in relation to being provided with interim accommodation. But it's obviously, do the maths, it's 19. We wouldn't necessarily have had a legal duty to accommodate under normal circumstances. Then after 3 weeks, the government was satisfied that across the country, everyone had been assisted that were in the cohorts of individuals in that sort of fragile housing situation, or if you were in the large city conurbations, you were people who were entrenched rough sleepers and the rights, that everyone was brought in, but they were satisfied that the offer had been made by everybody, and we could then go back to the application of the statute as it stands in law. And that's what happened just after the Easter period. But it meant over that period of time, obviously, authorities across the land now had a legacy of support and assistance and accommodation for a bigger cohort than they would normally have had, because we obviously offered accommodation and that had been taken up by a number of people. We worked with our registered providers because, again, during the lockdown period, there was no housing movement, there was no letting of accommodation. And we looked with our registered providers if they had empty properties that hadn't been advertised, if we could access those properties to move people on or move people out of a bed and breakfast sort of provision. The approaches for housing advice generally have continued throughout the whole lockdown period. Just general inquiries, that what we normally get anyway, but there's been more clients who've been approaching closer to a time of crisis, again probably through the pressures of this sort of lockdown and how we've all had to live our lives. We continue now after the sort of the easing of the let everybody in provision back to business as usual. So we're dealing with everybody who has approached since that time, all the people we accommodated during those first 3 weeks of lockdown, and everybody that we had before. So we're very busy as normal, but we have that obviously added pressure with people who we're working with, and those individuals will have individually a whole host of background, accommodation, history, behaviour and other types of issues that can prove a challenge to secure them affordable, sustainable accommodation with any provider as it starts to unlock. So we are starting to see our registered providers starting to sort of get back to moving towards more activity. Obviously their workforce is coming out of the lockdown, small sort of interventions, bringing empty properties back online. And so we obviously were taking and sort of signposting our clients to that provision as best we can if they can match those particular housing offers. So get good news on as much that we never offered accommodation. It was rejected to those in those first 3 weeks where that was available, and we were able to secure people with we weren't sort of, the door wasn't closed in our face as a consequence of some people who do have housing history that sometimes you know, that might stop us getting accommodation or be more of a challenge in the normal times. We were fortunate in that respect. Next slide, please. Looking a bit blurry. Okay, and just another one of my service areas is the environmental health, the commercial team. at the beginning of the COVID lockdown, obviously government introduced a closure of a whole host of businesses that would normally be operating, leaving us obviously with the supermarkets really at the hub of the businesses who could operate and were open for trade. So over the first 9 weeks of that period of time of a lockdown, we had just shy of 160 requests that came in. That were dealt with by the environmental health officers who make up the team. These would be complaints by the public. Obviously, it was new to us all, so people were putting 2 and 2 together and seeing a business thinking they were open and trading, or they shouldn't be trading. So there was a bit of obviously confusion from the public's perspective, and we were all sort of getting our sort of head around this. As well as obviously the businesses themselves wanting direct advice, clarity, can I trade, can I not trade? And we also had some survey work undertaken by officers just to test to see whether we were seeing businesses that were being compliant. We also have undertaken, it says there, about 4 times we've done some obviously social distancing, officers having a walk around our individual settlements around the sort of high street area, if that needs to be done on foot and can't be sort of driven around, just to see for ourselves that we do have compliance. The businesses that need to be shut for the time being remain shut, and those that are operating are applying the social distancing, and that's those control measures that we're all obviously becoming experienced of as consumers ourselves. We were advised of a couple of businesses, and we sort of undertook visits to these businesses as described, the licensed premises. We found there were some individuals within that premises that they were had been doing some works in the premises, but they were in all intents and purposes could be perceived to be making use of that particular business premises, a car sales business operator and a vape shop, and appropriately advice was given, or in the case 2 prohibition notices were issued, and they were all complied with, so there was no further need to step that sort of level of enforcement any further. And the car salesperson, obviously that changed on the 1st of June. So as it says there, we revoked that prohibition notice that had to be issued a couple of weeks prior because they were not allowed to operate under the restrictions imposed by central government. And during all through the process of this activity, we've also been giving a lot of advice to businesses so that they could be prepared for when the lockdown started to happen, and that'll continue to be the case because obviously we know that the high street, the business offer, will not unlock in its entirety on the next milestone being this coming Monday. There's still a number of businesses, restaurants, pubs, etc., where that is, that date is yet to be fixed. With the talk about when it can be in early July, but until it's set in stone, they're all sort of preparing. And we do have a lot of businesses that are sole business ventures, so they're not part of large chains. They don't have the luxury to so rely on that sort of infrastructure behind them. So they are obviously endeavouring to prepare or to put in place the measures for social distancing and to be compliant in the world in which we currently live. And then just your general other business activity, as normal activity, food complaints, accident investigations, etc., which is just the norm for that element of the team. But a significant amount of time obviously spent in just sort of helping the population and the businesses navigate the COVID-19 world as we know it at this time. Thank you.
Okay, it's Fran again, just another one from me. So just a little flavour of how we've been supporting communities, and I think we could take all day to talk about how we've been supporting communities and how communities have been supporting themselves, but just a few kind of highlights really. So the health improvement team have been working with all of our local sports clubs who clearly at the moment won't be getting any fees from people because they can't operate, and they do run on quite a shoestring budget anyway. So we've supported them to secure a total of £58,607 in Sport England Community Emergency Fund grants, which is brilliant because that means that they will still be able to operate once we come out the other side of this, and we know how important that is to our residents in terms of physical activity. But to add to that, since Patrick did the slides, we managed to secure just under another £20,000 on Friday just gone for our local football clubs around pitches, so that's brilliant as well. We've established across South Tees Public Health, we've established under the kind of Every Mind Matters and the 5 Ways to Wellbeing brand, we've established South Tees Wellbeing Network, which will be a platform for all providers of lower level mental health services to network and communicate what they're doing. So we'll have a real clear visibility on that, because we know how important that's going to be at the end of this. Members will know that we have a Borrow Box app, which means you've got to register with the library, but you can download the app and download books. And we've seen since during this period, there's been a 53% increase in the use of the Borrow Box app, which is brilliant. It means that people aren't missing out on their vital library services in terms of book borrowing. The community development teams, on libraries as well, I was just wanting to say that we've seen a 50% increase in library deliveries. So we've always done a library delivery service to the housebound residents in the borough, but we've been taking calls in the shielding hub, the community support hub, with people requesting book deliveries who are shielding or housebound. So we've been able to maintain that service, and as I say, it's increased by 50% in terms of numbers. The community development officers have distributed 300 community information leaflets to individuals who we know may not have. We know that everybody doesn't have access to a computer at home. I think all members were consulted in terms of their photographs and details being on those, but you know, they've been a real hit. So we've delivered them to homes out in communities, and they're displayed in prominent places with telephone numbers on rather than websites. The culture and tourism team have worked really hard as well to support a number of local groups to successfully secure, I think it's just over £120,000 now of Arts Council England emergency funding. So some of our local VCS organisations have secured quite significant amounts of money through that. And we've continued delivering some of our museum services throughout closure, again using new ways of delivering services with digital talks, workshops and exhibitions online. Thanks, Patrick.
And this next slide probably doesn't need a lot of introduction, but just to say, you know, as we're coming out of lockdown, as you know, we are going to get an increase in demand potentially, where people have been building up issues within themselves or within their family dynamics. So we are expecting, and some of it is already coming through, as Franz described, in terms of things like domestic abuse. Well, I've put it as operating in a socially distancing environment. I think Craig described it as a new norm, but the Department of Health and Social Care have said to us it's the new normal, and the new normal will last until a vaccine or a treatment is devised for COVID-19. And for a whole raft of our services, we have a new normal to work out what that is. Residential care. You know, most of you will be in a residential care home. It is very difficult to socially distance in that environment. There's always a high risk of infection, so social distancing in many ways becomes more important. You know, how suitable is residential care, at least until a vaccine comes forward. And then as listed there, we have a whole raft of services that in terms of, you know, we need to start to plan, think, work out about how they might operate in terms of a socially distancing environment. So there's a whole raft of things there, from, you know, what do we do with our libraries until the vaccine, our day centres that we have, you know. So there's an awful lot of planning and thought needs to go into this. At the moment, to be honest, the majority of our Work has been on dealing with the emerging crisis, but now is the time we now start to think about how we manage these services. And certainly if there are any significant changes, we will of course consult with Scrutiny, with this committee at the appropriate time. But at the moment, we're still just trying to get our heads together as to how we may operate some of these services in a socially distanced world. And then some very final thoughts that we have. Obviously, we've got backlogs to deal with in a number of our services. Not only backlogs that might have built up, but also in terms of that, we might get a surge in new social work assessments. So as families go back to work, they might be coming to us and saying, hey, I took my mum out of care a few months ago. She now needs to go back and have a daycare again. We will probably need to go and reassess her to make sure that the daycare now that she gets is the same. A whole raft of things that we need to do in terms of backlogs. It's already been mentioned in a couple of other presenters about the impact on the workforce. You know, we're remote working. That isn't ideal, remote working. Certainly for some people in themselves might have difficult home life situations. And then the welfare of staff, carers, and actually the biggest block of people who do things in the adult social care arena are the unpaid carers, and the emotional and physical toll on them as this continues, this socially distancing world. As I briefly mentioned in one of the slides, is about the effects on those people who have a lack of capacity to understand what is going on and what is happening to them, and decisions that might be taken around their care, whether they've got dementia or they're adults with a learning disability. You know, careful thought has to be given as to how we manage them and help support them to achieve what they want to achieve when they will have no understanding of what is really going on. The cost to us of providing services is increasing. PPE is a very obvious one. Another one is the shared care model. So we have promoted shared care through extra care schemes, people living in supported tenancies where perhaps two people share care. How will that work in a socially distanced future, however long that may last? There may be less choice for those accessing care. So if day centres can't open immediately, if people can't have communal support, the average person wants communal support, so they may be offered choice of their care, but that choice might be care where there's just them and a carer rather than a group setting for at least a period of time. And then probably the most important thing out of all is the overall mental well-being for the entire borough. And it's finished. I do apologise for how long it's gone on. It actually could have been 3 times as long, the presentation, but I'll stop there now for questions.
Yeah, can I just, first of all, before we actually go to questions, I would really like to thank Patrick, Craig, Fran, Victoria and Erica for all the work that they've done for this presentation. It was extremely detailed and we really do appreciate it. But I would also like you to pass on all of our thanks to all of your staff who've done a wonderful job. So I have got Councillor Philip Thompson said he's quite happy to have his questions answered via mail. So we leave Philip's questions alone for the moment. But the first person who I saw come in to ask a question is Louise. So can I ask Councillor Westbury to ask the question, please? And I will mute. Thank you.
Hiya, thank you guys. Can I just reiterate Councillor Hollyoaks, thanks to all the staff for their work that we've done over the last 3 and a bit months now going on. I've got a few questions, mostly health related, you know, that's my sort of area. So my first question is, I've been approached by one of my constituents who has asked me, when will routine treatment, so for example B12 in this case, be commencing back in GP surgeries? I know there was quite a bit of work done around that, so it's probably towards Craig more specifically.
Chair, sorry, it's Alison. If I can just interject, apologies. I think Patrick's still sharing his screen, which means we're struggling to get any other live feed of members on. So Patrick, can I ask you to just stop sharing your screen, please? Thank you. Sorry, I shall mute now.
So the question was around when routine GP services will resume. I think Councillor Westbury. Yep.
Yeah, that's right.
Yeah, okay. So I'm not able to give you a specific date or time around B12 injections. What I can do, I'll work with my colleagues in the primary care team to understand what the planned response is in terms of resuming routine services. It was my understanding that the significant majority of routine services had started to come back online, but I'll need to speak to colleagues in the primary care team and get some specific guidance on that. So yeah, are you happy if I provide a written response after the meeting and I can pick it up straight away?
Yeah, I'm happy for that. That's no problems.
Thank you.
My other question, obviously, this probably goes to both Craig and Patrick. I don't know about other healthcare providers, but myself, I'm sure the rest of my team, we're all pretty much doing double our hours and no annual leave at the moment. Obviously, that is unsustainable on any level. We're all pretty much on our knees in our team. I'm sure other teams across the providers are the same. What are we doing across the board, and this goes to all the sort of managements along this level? What are we going to do to make it so that this doesn't continue? Because I know we're moving into a new norm, but certainly within my new norm, that doesn't include any reduction in the crazy amount of overtime we're doing. So it was just to see, how are we supporting? Are we putting those adverts out to try and recruit and train additional staff? What's the plan? Because if we're waiting for a vaccine, we could be waiting for the best part of a year for this to go on, and certainly for myself, and I'm sure this goes across everybody in the sector, that's not sustainable to carry on the rate we've been working for that length of time.
No, I mean, from a health service perspective, I know that there's been a lot of work undertaken to look at the health and wellbeing offer for staff. So not only in terms of making sure that individuals aren't working ridiculous hours over a sustained period, but also making sure that they've got the right support in and around the workplace and outside of the workplace, so that if they feel that they would benefit from having some conversations with other professionals, that's available. In terms of recruitment, I'm not aware of any instructions that have been issued to stop recruitment. So there is no kind of recruitment ban or anything like that in place. We have been trying to bring additional staff and resources in. There has been and there is COVID funding available to support additional responses. It would be unfair of me to speak on behalf of the two foundation trusts, the local foundation trusts, or even CHUV, because I've not spoken to them directly around what they're doing to bring additional staffing in. What I can say is that in starting to talk through the recovery plans with these organisations, they're acutely aware of the impact on staff and the way that staff have been working over the last 12 weeks. And they're really clear that moving forward, they're looking to help support designing pathways and ways of working that reduce that additional burden on staff, because the NHS is its staff, and without our staff, we're not able to provide the services or offer the urgent responses that we have been. So it's absolutely vital that we have our staff refreshed and ready to go ahead of the winter, when there's a real likelihood that we'll be hit by not only winter pressures, but a potential second or further wave rather of COVID. So again, what I can do is ask for some specific responses from the provider organisations as to what they're doing. I know from a CCG perspective, with our staff who aren't necessarily frontline staff, but provide support functions, we are trying to work to make sure that staff do have downtime. We have had people working very long hours. At the beginning of the pandemic, we had staff working 5 or 6 weeks on the bounce. That's not acceptable moving forward. It's not sustainable. So we're trying to ensure that everybody takes their leave, everybody has some downtime, everybody's got the right support, pastoral support, peer support, so that they can have that time away from work when they require it. I don't know whether there's anything Patrick wants to say from a care perspective.
Just to reiterate, we're doing a whole raft of welfare things, very similar to what Craig's mentioned, and we are still trying to recruit. I think that the only dampener I'll put on it, though, is just being realistic about being able to recruit. Hopefully, in the care sector, the government, as part of their national plan for adult social care, was to increase recruitment into adult social care. But in terms of us being able to source more social workers. You know, we needed social workers at the time we were dealing with the IT crisis, but everyone wants social workers, everyone wants occupational therapists. So managing the existing staff and their welfare is absolutely critically important, because just recruiting will not be a magic bullet, because it'll be very, very difficult to achieve. But certainly an awful lot of work is being done, particularly by Victoria and Fran, around making sure that the welfare of the existing staff is protected. But it's very, very difficult when you are dealing with the services we deal with, where, you know, care has to be provided and supported, but it's something we are absolutely conscious and aware of.
Thank you. And if it's okay, just one last one, probably more Victoria's this one's aimed at. We've seen a few anomalies where care homes have had quite a few residents who have tested positive but have been asymptomatic. There's one in Gisborne I'm thinking of specifically in this case. Is antibody testing going to be something that's going to be done routinely once it's available within our care home settings? Or are we going to continue just routinely testing once patient has symptoms? Because obviously the Gisborne incident does indicate that actually possibly in the older age category there's still quite a lot of patients or people who are non-symptomatic with COVID.
Thank you, Councillor Westbury. I'm not trying to dodge the question, but I think there might be somebody in this meeting that may be able to answer it better than me in terms of the antibody testing, because I haven't been involved in some of the recent discussions about where we're at with that. Is anyone able to help, please?
Esther, are you on the call?
No, we were hoping for Mark, but he hasn't arrived yet. All I can say is I don't think my understanding is there's been a definitive decision yet in terms of the antibody testing. Certainly in terms of testing everybody, now care homes have the capabilities in terms of the testing regime to test everybody for COVID, and testing kits are being delivered to all care homes currently. But in terms of any sort of test to determine whether they previously had it, there isn't that information yet available, and I think probably partly because the government isn't aware yet in terms of the scale of when it will have enough tests to make any sort of pledge.
If I can, Chair, is that okay? Just in terms of the antibody testing, I think part of the issue with the antibody testing is the need to actually take blood. So there was originally two options, to have blood taken or to use a pinprick. But the test that relied on the pinprick has actually now ceased. I think there was too high a rate of false negatives coming back, so they've actually parked that test and they're relying on bloods being taken. So there needs to be a process to work through. How would you get the bloods taken in all the various facilities, and is there a willingness to allow perhaps community staff to go in, because we know that there's been concerns with some of the care homes previously around opening their doors and allowing community staff to come in. With the risk of cross-contamination, etc. So I think there's a little bit more work to be done on that, but it's something we can pick up with Mark when we next catch up.
Thank you.
Thank you for that, Louise, and thank you for the people who answered the questions. The next person who I've indicated I wish to speak is Lynn. So can we bring you in, Lynn, please?
Thanks, Chair. Thanks, Sheila. Yeah, I mean, don't apologise, Patrick, for your presentation. It's absolutely excellent. It shows the good work that all the council staff are doing, the NHS and our key partners. And I'd just like to also thank you all for the valuable contribution you're all making to help our most vulnerable and hopefully get us through this COVID-19. So don't apologise, it was really good. I mean, we feel like, I suppose a lot of members feel like we don't know what's going on. We get little snippets, so this was well worth listening to. So please don't apologise. Couple of questions, and there's some that I'm not going to ask because I think they'll come into other meetings. I think Resources Committee probably as well tomorrow. But my questions are, I hadn't seen the presentation, but it wasn't the presentation on the increase in domestic abuse and mental health. We knew that, but to see it's already over 50% is quite worrying. Now, in the report that you've taken to Cabinet and a little bit, well, I think it's the Cabinet one, it does say that we have plans. The council and partners are going to begin planning for spikes in mental health and domestic abuse. Suppose my question is, who is currently planning and coordinating this support? Because we knew it was going to increase and we can see it as. So who's actually doing that now? Fran, you mentioned that Leanne, the domestic abuse squad, is gathering information and talking to partners. But I'd like to know who's actually coordinating it all, bringing it together, who's the lead officer in all agencies, so all our partners across the board, and what plans are already in place, and then what plans are we looking at to actually, as it says, we're going to deal with the spike, which is already a spike now, and possibly could go even further. That's the first question. Do you want to just answer each question I'm going to answer that one first, yeah.
Yeah, that's fine. So do you want me to cover that for domestic abuse and mental health?
Yes, please, yeah.
Yeah.
I've got a couple more, but
okay. So for domestic abuse, obviously I talked when we had the presentation slide around the work that Leanne's doing in terms of coordinating what's already happening, what future plans are to look at increasing capacity. And as you know, there's been a lot of national funding for domestic abuse, and quite a bit of that so far has either been secured in Redcar and Cleveland, or we're optimistic it will be. So it's how we expand services to respond to the increased need. So we really are on that. I hope you feel a bit of confidence in that. Equally, we started we had a new model of commissioning our domestic abuse services for 2020, 2021, while we developed the long-awaited vulnerable persons model that keeps being put back a little bit because of cyber attacks and COVID. But yes, so our newly commissioned services started in April, as we'd anticipated them to. So that's the refuge, the IDVA service, the children's therapeutic service, and the perpetrator programmes. So does that answer your question for domestic abuse, Lynn? You're on mute, Lynn, I think.
Am I back on yet?
Yes.
I'm aware that a lot of the work that has had to be put on hold in terms of the work we've done with the homelessness strategy, looking at what I suppose a technical world, whole systems approach and so on. So it has answered and it hasn't answered, because what we haven't seen in any report yet, or no members have seen, is any plans. So there's no action plans. There's talk about Leanne's phone and she's speaking to people. We're not seeing this is the issues. It's gone up 50%. It's likely to continue. This is what we've done and this is what we're going to do. So I'd like to see something on paper where someone has took the lead and put all that information and data together, and then decides who's actually going to make sure that the people out there who are suffering domestic abuse, mental health, are actually going to get the support they need, because we were struggling before this. So I can't imagine, what in terms of resources we're going to need now. So I suppose to Craig, great partnership work, Craig, but we've always said that we need to look at health inequalities. This and that goes around domestic abuse, child poverty, homelessness, so on and so on. So I hope that partnership work, and I'm sure it will, but I hope it does continue. So I suppose it hasn't answered, Fran, because we still need to see that information on paper. Who is leading? Who can we go to and say, can I just have a look at how this is all working, and what the support's out there, where the funding's coming from. We know domestic abuse is going to get more funding. Where's the mental health funding coming from, and so on and so on. Do you want to come in, or do you want me to?
Yes, please. I think both Patrick and Rob earlier alluded to our recovery programme, which is the big, you know, we've responded to the crisis, we're now moving into the recovery programme, and obviously all of the services that sit within my remit, of which domestic abuse is one, is, you know, our approach to our recovery, if you like, which we are in the early phases of it. What did it look like before? What does it need to look like in the future? What do we understand from this COVID period in terms of has need increased, which we know it has for domestic abuse? So future planning, because I think when we look at all of the services, we are going to have to make some quite difficult decisions in terms of if there's greater need in domestic abuse, but less need for another service area. I won't shoot myself in the foot and mention one, but you know, then we need to look at the big resource that we've got and how we move it to respond. Yeah, definitely.
Yeah. Thanks, Fran. Second question, because we haven't got a children's, I don't think there is a separate children's scrutiny. So the number of children in care has gone up to 352. That's an increase of 50 to 60 more children taken into care over the past 12 months. So following on from that last question, have plans been put in place to develop a coordinated response across the council and with key partners to address the serious issues of children in care, mental health and domestic abuse? I did put drug and alcohol addiction on that question, but from the figures at the moment, it hasn't increased, but I'm sure we never know the real figures of drug and alcohol addiction. So I suppose it's just, you're probably going to answer the same as the last one. We need to see a coordinated response for these services that are actually already in crisis before this, but are increasing to a level that we really need to see some action now. I think in terms of, we've dealt brilliant with COVID-19, but the aftermath of it, this needs seriously to be a priority now. And then the next one is we already had a strategy, and a really good one. I don't know if it turned into a strategy, but there's lots of work going on behind the scenes in terms of homelessness and looking at prevention and the underlying issues. So not just looking at homelessness, and so I think there's funding. I'm not 100% coming from government to tackle homelessness. So I'd just like to ask yourself, and probably as well, if the cabinet member does want to come in, when are we going to actually put that strategy into action as well? So is the funding available, and is that funding going to be used to bring the, obviously, and Erica can come in as well, I suppose.
Sorry, Lynn.
Put that homelessness strategy now, action it.
Yeah, I'll do the bit about the children's services, because I've had a dialogue with Linda Bulmer before we started the meeting, and then Erica will cover the homelessness one. So, you know, as you know, they have seen significant increases. I think the North East and the North West have had the highest increases in terms of children in care. So they've completely reviewed their team structure. They've introduced an additional team manager post and some new family support workers to respond to the increase. They've recommissioned, based on your mental health of young people kind of element of that, they've recommissioned in-house looked after children CAMS service. And they've introduced an in-house therapeutic service, and they successfully bid for some funding for some family group conferencing, which I think the Link are going to deliver for them, and they bring families together at that critical point where children are on the verge of going into care. So hopefully that stops them going into care. And then a lot of what Linda said was a lot of the increases have been down to the toxic trio, which, you know we don't underestimate that, do we?
No. Which is why, again, that we need to get on top of it. Yeah,
definitely.
Right. Okay, Fran.
Yeah, all right.
Thank you. Yeah, thanks for that.
Hey, thanks for that, Lynn. Can I just remind people that if you're not actually speaking, to remember to turn your mics off, because it does make the rest of us being able to hear it so much easier. The next person I've been asked to call in is Deborah. So do you want to come in, Deborah, please? I'll turn my mic back off.
Yes, thank you very much, Chair. I do have just 3 questions, one for Patrick, one for Erica and one for Fran, on a lighter note, Fran. The first one, Patrick, regarding educating the people in the care homes, the carers. I did send you an email about carers in the community with their uniforms on while they've been working in nursing homes. Would this training in the nursing homes have covered that point?
I'm looking at Victoria and she's nodding away, so yes, it does.
Oh, good, marvellous, marvellous. That's great. Now, my other question was for Erica. Erica, what it is, again, I mean, there's the commercial side of things, but with the shops that are open, such as like Tesco's and so forth, where they've had the cafes, I'm not sure if these people are actually deep cleaning these cafes after. There's nobody in them. They need, it sounds awful, this, but a deep clean and such like, because people are still going in those shops and the areas aren't kept clean. There is an incident when I go to a supermarket, and every time I stand along that row to go into it, the same things have been on that shelf ever since the lockdown came about. So tomorrow when I go, I'm going to say to them, are you going to move that stuff and wipe the top down? Because, I mean, it's pretty bad news when even the shops can't really keep on top of things and just keep things tidy. Do you go in there and talk to them about hygiene or anything?
So sorry, Cancer, in the supermarket, a bit of reverb. Okay, yeah, in the supermarkets, the cafes that they've had, that, you know, the biggest supermarkets, they've been closed. Yeah, so they've not been used at all by the members of the public. Obviously, it's retail to take out the shop, nothing to be consumed within the shop. It's similar to any other high street sort of provision. I personally have seen in my local supermarket, the one I've been able to get in, they've stripped it bare and they've tables, you know, upturned over, etc., and they've used it, or not used it, but it's not been operational and it's just got thicker with dust, I suspect. But no, putting that aside, depending on what you're seeing, it shouldn't be for retail. It's obviously not being manned, not being staffed. If you want to ping us the information, if it's a supermarket in our area, we can have an eye on it and see if there's been any sort of complaints or otherwise. But if it's a non sort of retail area, it's not for retail purposes, those items, whatever they are, then ultimately we can sort of add it to the list to have a look, see as to whether. But we've given advice, you know, we've had a lot of complaints that have been unsubstantiated, or it's been that confusion between interpretation and what the guidance is saying. So one size doesn't fit all. So until we actually have a look, see, there might be something that we can recommend or suggest, or it's just been an oversight in their sort of close down of an area and focus on the active area.
Yes, thank you for that, Erica. One last thing for you, Fran, and it's a bit of a light note here. If you'd seen your presentation, last piece, supporting communities, on the side you had every mind matters, and underneath you had the borrow box. If you look at it, yeah. So you can borrow a mind anytime you want.
No, you can borrow a book or a jigsaw, Councillor.
I know.
It'll help your mind.
Right on. That's me finished. Thanks very much, Sheila. Thank you, Fran.
Thanks a lot, Deborah. Yes, I never noticed that. That made me laugh. I think sometimes we need a laugh, don't we?
Sorry, Councillor, it was in relation to this Erica here. It's just the question that Councillor Pallister had about the homeless strategy. Do you want me to answer that now before we move on to other questions?
Yes, please. Yeah.
Okay, so the homeless strategy, or the new home, it's title being the Homeless Prevention and Rough Sleeping Strategy, to give it its full title. It fell between the COVID and the cyber attack period, so it's done, but it just needs to go through the council sort of sign-off process after consultation and the like. So in relation to the funding matters as well, predominantly the funding that's been announced has been focused around rough sleeping population and not the wider cohort of homeless clients who fall within a whole different sort of pathway of prevention, threatened with homelessness, etc. We are fortunate in so much that we have such a low number of rough sleepers that ever report to the borough, verified or not, no entrenched rough sleeping population. It meant that when the government gave funding allocations at the outset of COVID, our allocation was, wait for it, £1,600 in its entirety, because it reflected our return and our sort of numbers with regards to rough sleeping. But nevertheless, we had, long before COVID, as a region in the North East authorities, we worked collectively on these agendas because the 12 authorities, as you appreciate, that make up the region, and the sort of just thinking about the physical, the geographical spread and like the rural urban nature, we all have different challenges to some degree or another, some of us more than others, but collectively what the government like to see is that collective bidding and that shared work and joint working, which we've done successfully for a number of years. So we have, as a region, prior to the whole COVID agenda, secured successfully Rough Sleeper Initiative funding, of which we get a part of that. So that was long before COVID, and we've had access to that. It's more than 1,600. It's about, the last year was about 15 grand or thereabouts, which we help to sort of pre-purchase and help people, especially over the severe weather provision that we need to sort of bring people in under SWEP as well. So it's not a new agenda, but the money is at this moment focused in the sort of the rough sleeping entrenched population, which is fabulous for those who've sat out of services, have been very difficult to engage with, and getting into accommodation has been problematic in other areas nationally for a number of years for a whole host of reasons. But looking forward now on funding that could come about, and they're talking about it nationally, is that because of the homelessness situation, or the sort of the COVID situation and its sort of knock-on effects to housing, you've got lots of people who have felt, obviously, the whole unemployment has happened and will be happening. You'll have homeowners and renters, private and social, that'll be faced with significant arrears. There's been no repossessions, that's on hold, but that will have to and or will come about again in the future. You've also got people who've heard the word mortgage holidays, and some people wrongly have thought of rent holidays when their financial position hasn't particularly worsened, and that's sort of borne out some of the very limited information we're hearing from registered providers. So that whole issue that we went through years ago of mortgage repossessions and the money government put to that, which we were successful in securing and administering and helping people in our borough, I think we're going to see, the expectations, we're going to see that come back again, and that need. So I think that's where the next tranche of money will look towards, the wider people forced with losing their homes, whatever tenure, because of the legacy of the impact of COVID.
Thank you for coming back so quickly with that one, Fran. Thank you. I'm going to bring in Councillor Carl Quartermain now, who's actually subbing for Councillor Brady, so he's allowed to speak as a member of the meeting. So over to you, Carl.
Okay, thank you, Sheila. Can you hear me okay? Okay, so can I just say thank you all for this pilot first public virtual meeting for Redcar and Cleveland. It's not easy, not ideal, but extremely important. We adapt to this new normal and get back to business as usual. And it shows, you know, the weight of the information we've received today just shows just how much this has been needed. And I do hope it also improves public engagement and provides knowledge and better understanding of how local government works. And I'd like to offer also my thanks and praise to our council staff and partners for their response to the support for the most vulnerable and clinically vulnerable residents with our food parcels and provisions and interaction as well, very important. And I think Redcar and Cleveland, we're blessed by volunteers and a strong community who've all pulled together. And of course, we were absolutely indebted to our NHS and our care workers who have shown, a great resilience during such a difficult time. And all of them have our eternal gratitude and respect. I've got a few questions. We've so far received £8 million from the government and to deal with the impact of the virus. We already recognise this is not going to cover the losses to this authority, and the indications are that we are going to be 2.7 million short. But we believe there's going to be more than that. Has there been any further analysis and estimation as to the actual shortfall? My second question is in relation to the Local Resilience Forum test centre on Redcar Racecourse. This hasn't been publicised very well at all. Residents don't know whether to drop in, whether it's a drop-in service, if it's only if you are showing symptoms, and how to make appointments. I have been directed to the Government UK website, but I think we need better information coming through the council to support this local offer. My third point is we also need detailed information regarding the operation of test, track and trace. The government have really dragged their heels on this, but we are limited with the knowledge, so require more advice and guidance on that. My fourth point is there's an indication that there will be a second spike. How will we manage this properly? And if we have to lock down the whole borough again, who makes those decisions? How will this be publicised for a quick response? And how will it be policed? And my final point is how quickly will measures be taken to put the high street, to open the high streets back up and make them safe through the funding that's been made available through the council? And I'll stop there. There's obviously a whole plethora of questions that we all want to ask, but given time, appreciate we just haven't got that. And thank you again, everybody. Much appreciated this meeting.
Thanks for that, Carl. I think a couple of your points will probably be better off answered at the resources scrutiny tomorrow morning. I don't know what Patrick thinks, but if Patrick, is it hand over to you to answer what you can? Thank you.
Yeah, I'll try and give a quick response to all of them. Yeah, certainly it is being scrutinised because we're being scrutinised on how much we're spending on COVID-19 by corporate finance. But all I will say is that if there's money that we need to spend to what we believe is protecting the residents, then we're spending it. But obviously, we are careful with our money. But yeah, I think any more detail on that is best being directed towards resources scrutiny tomorrow. Yeah, I take your point about Redcar Racecourse. It's very difficult to advertise it because it's very late in the day. Well, we didn't know until it was approved as a site, but then it's still by us locally. Then we needed Department of Health and Social Care approval, and then by the time we knew it was approved, the first date had already been set, and there was like 24 hours notice. So it certainly, and it's been put in for more days this week, only at a last minute because of Teesside Park pulling out. But I certainly, so in terms of advertising when it's there, it's very, very difficult to do in advance. We certainly don't know where it's going to be next week, what days it'll be at Redcar next week yet. But certainly it is very complicated, and I appreciate how the average resident doesn't understand. Can I turn up? Can't I? Do I have to have symptoms? Don't I? I've struggled to understand it myself anyway. So we will have a look at having some very, very simple information that can just be given out to people that maybe we can put in the members' bulletins, or members know if they get a query from residents, or work on that one. In terms of the track and trace, it's still in its infancy. There is a local health board being set up. I can't remember the exact name for it. that's being set up at the moment. It's being led through South Tees Public Health, but some information on that will be coming out shortly. In terms of local lockdowns, the way how the law currently stands is that local lockdowns can only be implemented by national government. So there may be some change to the regulations to allow the local director of public health or whatever this health protection board is going to be. But at the moment, my understanding is that locally, so Mark, as a director of public health, will have the authority to determine where the local testing site will be if there is a local outbreak, but it will still take a national decision to impose an enhanced lockdown on a local basis. That is, I think, because these things are happening so quickly, that like the law is catching up with and I think another councillor has asked that question. I've seen the answer earlier about local lockdowns. That's how I know what it is. In terms of the high street, there are certainly plans being discussed, because I've seen some myself, about how the high streets, again, that is something that I know that the GEE department are working on at the moment, because I've been involved in discussions with it. Again, it's happening at breakneck speed. So I would imagine something will come out shortly about the use of I think it's £86,000, I keep on getting told, that is available in terms of supporting around local issues around supporting the high streets to reopen and increasing the sort of footfall rather than people driving. So I'd imagine something on those will be coming out very shortly, certainly due to the fact that the high streets are going to be opening again imminently. So I've done my best to answer those questions.
Thanks for that, Carla. Thanks for that, Patrick. I haven't got any indication that any other members wish to speak, or anybody really. So I think the next item on the agenda, so really thank you all for taking part in that.
Sheila,
yes,
I've been waving away, but
I didn't see you, Mary. Yes, of course.
I joined about 5 minutes late, and I did ring David and said, had they seen that I was here, I have been here all the time. You'd be glad to know.
Oh, sorry, I'm just interrupting there, Mary. I didn't know you were here.
All right.
But obviously, because I couldn't see you and it didn't come up on the chat, I didn't know you wished to speak. Well, yes, yeah, I'll let you get on with it.
I'm hearing myself, but can you see me waving? No? Can't hear you.
I'm muting myself, Mary, so you can speak.
Okay, thank you. I just wanted to say a big thank you to NHS, all of our staff, and care staff, and all the volunteers who've helped, just to reiterate what everybody else has said. It was going way back to Craig, actually, when he was talking about doing things in a different way and setting aside finance. I think we've found a way for partners to work together because we've been forced into this. And I can give you one clear example. My grandson normally has to go up to the RVI to have blood tests taken for his juvenile arthritis. He was able to have them done at James Cook, and why that can't always happen, it's only happened because of this situation, and I think it's that willingness to work together. Having said that, if we were doing more testing there, we might have to see how our labs and what have you could deal with that, but that seems infinitely better. They're not spending all that time polluting the atmosphere going up to the RVI, and there's not any need. And in fact, they had their consultation with the consultant via visual, so it's going to be a different way forward, and it fits in with kind of looking at the staff all around, because there has been much talk in various places about having just specialist centres with more remote workings. So just to pass that on to Craig. And finally, when we think about mental health, and that's going to be a biggie for us, and trying to get over this fear that some older people have of going out, I think it's important that we try to get as much normality as possible, and also to bear in mind organisations like Mind and how we're going to use all of our resources together. Thank you very much.
Oh, thank you for that, Mary. Yeah, Jenny, didn't you? Right, the next item on the agenda is the relevant cabinet reports, but I don't think, Patrick, I'm right, we've got any cabinet reports in our portfolio, have we?
No, the only report of any relevance was the one Rob did earlier.
Right.
Because I did indicate I wanted to speak, I put a little message.
Well, I haven't got your message.
Well, I definitely typed it out, so I can't understand that.
It's not come through.
Right. But have other people's come through?
Through. Everybody else has just come through, apart from yours, Steve, so I don't know what you've done. But yes, if you wish to speak now, because we've literally got about 15 minutes left.
Right. Well, I must have been first to request. Anyway, I know I have to wait till the committee's finished. Right. Can I congratulate the 6 presenters who passed the baton on very expeditiously? It's the longest presentation I've ever been to in 41 years as a councillor. So you can be proud of having made a record. With regard to a couple of points that Lynn made on domestic abuse and children, yes, it's obvious from what's been said to us that this, I think I join you in believing that it should be a high priority. And I'll make it the subject of a meeting with Patrick and Fran in the very near future to discuss this, because, you know, I think you're right in what you've said. Now, I was interested in what was said by Patrick and I've forgotten who else said it. Anyway, on the resilience, because really we don't know where we're going with this. We don't, you know, we've got to prepare for a whole range of options, and I think this is perhaps going to be a difficulty. However, I, for one, am optimistic, and I think we will get back to the old normal. A vaccine would be a marvellous thing. Once we've got a vaccine, herd immunity will take effect. And there are also developments in antibody treatments and antiviral treatments. So I think there is hope, and I think within a year we will be back to pretty much what we used to be like. Although we have, I think, or we should have learned a lot from this, particularly about working together. And I think it's marvellous the way that the voluntary sector, the council, the NHS, because of the emergency, we need a war or a pandemic, and then we start working together and getting more and more efficient in doing this. The question I would like to ask is I think it's to the NHS as much as anybody, is the decline in deaths partly owing, at least, to improved techniques of treatment in the NHS? In other words, I'm asking, have things improved with regard to treatment thanks to or it's a funny word to use, thanks, because of the experience with people who have been unfortunately taken into hospital with this awful disease? I would like to comment also on my dissatisfaction with the government at many levels being unprepared, locking down too late, coming out of lockdown too soon, and this atrocious decision that Patrick mentioned on the 2nd of April, when people who were potentially COVID positive were allowed back into care homes. I think that was absolutely inexcusable. And so I know probably you've got to be a councillor to say this, the officers can't say it, but I think the government's handling of this has not been very good at all. And when you look at our population, we must be the worst in the world. Certainly in the first world, we've got the worst record. And I'm ashamed of it, to be quite honest. But I don't think it's the fault of the council, the NHS, the volunteers, the care homes. It's the fault of the government making belated or inappropriate decisions.
Thanks for your observations, Leslie. I honestly don't know if, because Craig's actually left the meeting, he had another meeting, so obviously I would have thought that question would have gone to Craig. But I'm sure what I can do is ask Patrick to get an email to Craig with that question on to get a response, not just for yourself, but for all of us. So I think actually,
Chair, you've muted yourself.
oh, sorry. I think as far as I was going to say, I'm doing this to people, just saying I think that's the end of the meeting. Hooray! So can we just say thank you to everybody for participating? You've all behaved very well. So I'm really proud of you all. But again, I'd like to reiterate, I think on behalf of everybody, our massive thanks to everybody. Somebody's got their back. Just say thank you to absolutely everybody, and obviously as councillors, if there's anything at all we can do to give you support, just call on us. So thank you, and I'd like to give a special thanks please to both Alison and David, who have given me so much support in trying to work out my way around this system. They really have been invaluable. So thank you, keep up the good work, but don't forget to look after yourselves as well. Right, thank you everybody. Right, bye.